Selamat pagi Ibu Bapak hadirin sekalian, terima kasih telah hadir pada acara pagi ini. Kami akan memulai sesi sebentar lagi. Sesi pagi ini akan dilaksanakan dengan bahasa Inggris. Oleh karena itu jika membutuhkan alat interpretasi, Bapak dan Ibu dapat meminjam alat tersebut pada meja interpreter yang terletak di sebelah kanan ruangan ini. Good morning ladies and gentlemen, thank you for gathering here. We are going to start the event shortly. While we wait, the foyer area is available for you to visit, and interpretation tools, if needed, may be lent on the desk on the right side of the room. And please don't forget to return when you're done. Ladies and gentlemen, before we start, please allow some time for the hotel management to conduct a safety briefing. Bapak Hartono, Fire, Life, and Safety Manager, Shangri-La Hotel, will deliver the safety briefing.
Ladies and gentlemen, good morning. Welcome in Hotel Shangri-La Jakarta. Please may I introduce my name Hartono as Fire Lab City Manager. Okay, now we are in the grand ballroom. They're located at the second floor. Next. Just for your information, this room has a few emergency exits for the right and left and can be used without any instructions. And we have fire protection and fire detection like the sprinkler, smoke detector, and speaker, and fire extinguisher in this room. If there is emergency situation and immediate evacuation required, there will be announcement from silent speaker in 4 different languages, in Bahasa, English, Mandarin, and Japanese. And we have the emergency response team 24 hours and standby available to giving assistance for emergency situations. And we have a 1 unit ambulance car available in the ground floor, level 1. And there is also, we have the in-house clinic that located at the 4th floor. That of them is available 24 hours. And in case you feel unwell, we have a medical team on standby in the help desk outside the main ballroom. Our assembly point behind the building near the swimming pool, we set Steria Gardens. And we have the second assembly point behind the building or in front of the BNI building. There is our second assembly point. Thank you very much.
Good morning, Excellencies, honorable speakers, distinguished guests, ladies and gentlemen. How are you today? I hope you're doing well. First and foremost, we would like to extend a very warm welcome to all of you for joining us today at the launch of the White Paper for the Design of Indonesia's Health Sector Development 2024-2034. Policy Directions and Recommendations. This paper and launch is brought to you by CISDI, Center for Indonesia's Strategic Development Initiatives, endorsed by the Chatham House. My name is Sophie Sharif, and I will be your host and moderator for today. A sincere welcome we would like to extend to our distinguished speakers and guests, Mr. Robert Yates, Executive Director, Center for Universal Health, Chatham House. Ibu Diah Satyani Saminarsi, Founder and CEO of CISDI. Dr. Abdul Malik, Minister of State for Gender, Family and Social Services, the President's Office of the Republic of Maldives. Bapak Suharso Monoarfa, Minister of the National Development Planning of the Republic of Indonesia. Profesor Herawati Sudoyo, Chair of the Medical Science Commission, Indonesia Academy of Sciences, IP. Profesor Yodi Mahendra Datta, Dean of Faculty of Medicine, Public Health and Nursing, University of Gadjah Mada, Professor Kent Buse, Director of Global Healthier Societies, the George Institute for Global Health, Dr. Karen Ground, Senior Fellow, Global Economy and Development, Brookings Institutions, Ibu Irma Yunita, Assistant Director General, Puskesmas Acceleration Indonesia, and last but not least, Ibu Gita Syahrani, Head of Secretariat, Lingkar Temu Kabupaten Lestari. Thank you very much for receiving our invitation, and we are very honored with your presence here today with us. Ladies and gentlemen, CISDI has conducted a study and is publishing a report titled White Paper for Indonesia Health Sector Development 2024-2034. The study was carried out with the aim of providing recommended policy directions for health policy makers, development actors, as well as material for adoption by the incoming new government who will step into national leadership in 2024. As part of the civil society communities in Indonesia, the team of researchers aspire for this paper to function as a public health compass for the greater public. Before we proceed to the white paper launch, presentation, as well as panel discussion, we will listen to several keynote speeches and video messages. The first keynote speech will be delivered by Mr. Robert Yates, Executive Director of the Center for Universal Health, Chatham House. Round of applause for Mr. Robert Yates. The stage is yours, sir.
Thank you very much indeed, Ubu. Honourable Minister, distinguished guests, ladies and gentlemen, it's an absolute thrill and a pleasure for me to return to Indonesia. I had the privilege of working in your lovely country about a decade ago. In fact, at the previous transition, you might say, the political transition when Pak Jokowi became president of the Republic of Indonesia. And it's very fitting, I think, that I'm returning now sort of 10 years later and delighted to have this opportunity to talk to you about the politics of universal health coverage, and this being a political window of opportunity to potentially accelerate progress to UHC in Indonesia. So I just have a few slides to run through, and to start with, to define what we mean by universal health coverage. I think it's important to do this because people have sort of different conceptions about what we're talking about when we're looking at universal health coverage. And notice in this definition, there's no reference to insurance. We're not talking about people necessarily having insurance coverage. This is all about everyone receiving the quality health services they need without suffering financial hardship. So these three aspects to universal health coverage: the universality, everyone must be included. The people accessing healthcare according to their need. People obviously need more healthcare than others, and health services should be allocated and consumed on the basis of need. And also this very important aspect of financial protection. In accessing healthcare, people shouldn't suffer any financial hardship. And I'm very keen in the next 15 minutes or so to talk about the politics of this, that, you know, transitions to universal health coverage are inherently political all over the world. And I think this sort of slide illustrates perhaps why that's the case, because access to healthcare is extremely popular. People want it. You know, as a household member yourselves, you know, that you want it for yourselves, you want this for your families. And at the beginning of the pandemic, the United Nations conducted a survey across the world. 1.5 million people were asked what they wanted their governments to do. And access to healthcare came top by absolutely miles. Now, you might say, you would expect that, wouldn't you, in the middle of a global pandemic? But I think it really is illustrative, you know, that people have these expectations and wants that their governments give them access to healthcare. So perhaps we in the health world don't often sort of use this information enough when talking to our political leaders, that this is something that households really, really want and have expectations that their governments deliver. And moving to universal health coverage, obviously you have to reform all your health systems, the human resources, the access to medicines, the governance, but financing is absolutely crucial. If you don't get the financing right, you can't achieve universal health coverage. And there is now this consensus around how you do finance universal health coverage, in that a market-driven health financing system where people just buy and sell health services like they would buy a restaurant meal or a computer will never achieve universal health coverage. And quite simply, that's because in a market-driven system, only the rich people will be able to afford the more expensive services. So what you really need is a system whereby healthy, wealthy people subsidize services for the sick and the poor. And for this to happen at sufficient scale, that so even the poorest people can get the best health care when they get seriously sick, the state must get involved in the entire health financing system in determining who pays what into the system, how it's then pooled to create a big sort of pot of funds, and then what services are purchased on behalf of the population, with equity driving this whole agenda to make sure that the bulk of the funding goes to those with sort of greatest needs. Now, this doesn't mean that the private sector can't be involved. Quite the opposite. That the private sector can be heavily involved in providing services, and it's very much the system that you have here in Indonesia, using public money but paying for services in the private sector to benefit everyone. And just to sort of reiterate that this is the consensus now. This is Dr. Gro Harlem Brundtland, when she was speaking at the United Nations high-level meeting on UHC, not this last one, but in 2019, where she says, if there's one lesson the world has learned, you can only reach UHC through public financing. This is the key. How does one raise sufficient public financing to make sure that it benefits the entire population? And is a journey that Indonesia is going through, like every country in the world. And I just want to emphasize that this transition to UHC is led by politicians, that by putting a lot of public financing into your system to, in effect, socialize the health financing system is such a massive undertaking that it has to be done at a head of state level. Obviously involving the Ministry of Finance too, but it's very rare that a Minister of Finance will voluntarily do this themselves. They usually have to be encouraged to do so by the head of state. And I just want to give you one or two examples of countries that have made such a transition, often at quite difficult times. Now, the world at the moment in the early 2020s has been suffering multiple crises, from COVID and crises involving conflict and the climate emergency. The world does feel a sort of quite a difficult and insecure place at the moment, with multiple crises taking place. So you might think this wouldn't be a good time to launch universal health reforms. But the strange thing is that this is exactly the time this has happened through history. And to illustrate this from my own country, that we launched our National Health Service at the end of the Second World War when we were bankrupt. Our country had been destroyed in the war. We were a post-conflict state dependent on US aid, but we launched the National Health Service in 1948. And the picture on the right was when we celebrated this, when we hosted the Olympics in 2012. Our National Health Service, we see as one of our greatest achievements, launched at a period of crisis. Another country that much more recently launched very, very popular and successful universal health reforms was Thailand in 2001, after the Asian financial crash, when Thaksin Shinawatra was elected Prime Minister. And interestingly, at the time, the World Bank said to the Thai government, you cannot afford to launch a universal publicly financed health system. The country's bankrupt. And Thaksin ignored them and went ahead, and they've been very, very successful reforms. And the World Bank acknowledges that that was a really, really smart thing to do. So at a time of financial crisis, the government launched these reforms, and they have remained very popular since. And of course, Thailand had an election this year, and Thaksin's party is now back in power. He's not prime minister, but these universal health reforms have been pivotal in his success and his party's success. Another example of a country that really relaunched universal health reforms was China after the SARS epidemic in the early 2000s. It had had a very successful publicly financed health system. Had rather let the market take over in the 80s and 90s. But it was the SARS epidemic that really made the Chinese government realize that its health system had become predominantly privately financed, and therefore hundreds of millions of Chinese people weren't accessing healthcare at a time of a health crisis. So since about sort of 2003, 2005, there's been this massive investment in public financing, mostly tax financing, to subsidize health insurance for the entire population. And this increase in public financing is in the order of $500 billion a year in public financing. So that's another example of a country that sort of, you might say, re-socialized its health financing system after a crisis. And of course, there are countries that are still working on this journey. The United States, quite famously, is the only country in the OECD not to have a universal publicly financed health system. And the government is very aware of this. This was a tweet that President Biden put out very soon after getting elected, that he was going to work with Congress to try and achieve universal coverage and lower healthcare costs. You can decide whether it's been successful on that mission or not, but it's still the case that about 10% of the American population aren't covered at the moment. But then interestingly, at a state level in the United States, you have some politicians. This gentleman is the governor of California, who is trying to push through a single-payer health system in California, and only about 3 weeks ago signed a bill that lays the foundation for that possibility. So might it be that in the United States that you get a state-by-state approach, which, as I'll point out in a minute, I think you're aware of has been an approach taken in Indonesia as well, that certain states and provinces have raced ahead of others in achieving universal health coverage. And I just want to mention very briefly a commission that we've set up at Chatham House that is really recognising that these are political processes and that we need to be talking to politicians about this. If we're serious about these big, rapid transitions, how can we work with political leaders to encourage and inspire them to take out these reforms, particularly at a time of crisis? So we've set up a commission co-chaired by the former president of Tanzania, Jakaya Kikwete, and the former Prime Minister of New Zealand, Helen Clark, who's sitting in the middle there, to talk to politicians about the merits of running on UHC reforms and implementing them. And the lady on the right there is actually the former health minister from Ukraine, who herself pushed through very bold universal health reforms after the first Russian invasion in 2014. So we're specifically trying to have these conversations with political leaders about the merits of running on a universal health platform. And this was from an event we had earlier in the year where we met the Prime Minister of Bangladesh, Sheikh Hasina, to talk to her about the potential for Bangladesh to implement UHC reforms. And Bangladesh has elections coming up at the turn of the year, similar to Indonesia. So let's see if Bangladesh might take this opportunity, grab this political window of opportunity, as I say, to launch universal health reforms. But I'm very keen, obviously, to talk about the situation here in Indonesia and to speak very openly about what I think is a great political window of opportunity that's opened up again here. Because you'll all be aware that I think within a month of coming to power back in 2012 as the governor of Jakarta, that Jokowi introduced the Jakarta Universal Health Scheme, very, very popular, very successful. I remember I was working for WHO at the time, and this just came from nowhere. And I remember saying to the WR, wow, you know, maybe Pak Jokowi is going to be the UHC hero of Indonesia. And we were very lucky that we were able to work with the then governor. And in fact, he gave me, I still carry it around to this day, my KGS card, which I was very sort of proud to be part of the team sort of advising him on these reforms. And you'll be fully aware that back in 2014, this was a photograph actually taken of the presidential debate live on television, where Pak Jokowi took out, I think this was a green card rather than an orange one, and said, I am going to do for the entire of Indonesia what I did in Jakarta. And I think the majority of you will know how successful that was in his election campaign, and that he's obviously done 2 terms since. So it's just like across the world, like in my country, this is very, very popular. But then the question is now, what happens next? And you can reflect on how successful the reforms have been over the last 8-9 years. I show you this graph to illustrate that you can see in the numbers the change in policy. The red line this is health expenditure as a share of GDP in a number of countries. And you can see that at the beginning of the century, the red line, that Indonesia was one of the lowest of this sort of group of countries, spending less than 0.5% of GDP. And that was still the case pretty much when Jokowi came to power in 2014. Since then, you have had this gradual increase, and you'll be aware that more and more people are in the JKN now, and there has been this improvement. I think all the figures tick up at the end there, because that's a COVID effect, of course. You know, the country's suddenly having to plough a lot of money into their health systems. But you can see that Indonesia is still not at the same level as some of these other countries that I've already illustrated, Thailand and China and Morocco, I put as well as an interesting case, that have put a lot more money in and are at an expenditure level in excess of 2%, coming up for 3% in some of these countries now. So you've seen that Indonesia has moved away from the likes of India and Bangladesh that have been flatlining at about 1%. Progress has been made, but I think you'll be aware that, you know, there hasn't been full population coverage yet. There are issues around supply side, access to medicines, particularly in more remote areas of the country. So there is undoubtedly still scope for another leap towards universal health coverage. And it's not up to me at all to sort of suggest what those policies should be, but looking at some of those other success stories from Thailand, from China, from across the world, where countries have suddenly taken a big leap, and you can say, wow, that was a massive UHC reform. They've often been this sort of type of strategy to move to full population coverage. And Indonesia has done very well, and you know, I know the official figures are about 90% coverage at the moment, but I think there are issues about maybe people in the informal sector not keeping up with their JKN contributions. We are aware that there's a sizable part of the population, the sizable part of the electorate who aren't covered at the moment. So I think there is the potential to move to full population coverage, entitling everyone to free membership. Now, that basically means tax financing people in the informal sector. And there are costs associated with that, but we can see the simplicity of just saying, just like Jokowi did when he was governor of Jakarta, everyone can have a card who wants it. To do that, one needs to spend about 1% of GDP in public financing, which is a significant amount of money, but other countries have done that in recent history. So it is doable. Obviously, if you're spending that type of money, you want to spend it well. And so therefore, to concentrate that expenditure on primary healthcare services and strengthening health systems, and where I think the population would see the benefits very quickly is guaranteeing access to free medicines and diagnostics, particularly for NCD medicines, to make sure that people get regular supplies. Maybe they don't have to go to the Puskas every 2 weeks for their medicines. They maybe get a month's supply of medicines. That's where people really do notice the difference. Now, you might then say, how could this be paid for? Well, quite simply, this would need an increase in public financing, and the most efficient way of doing that is through taxation. And one is aware that taxation levels are still quite low in Indonesia, so there is definite scope to increase taxes and maybe find other ways of finding fiscal space by cutting subsidies on things that don't make sense, like fuel subsidies. One might say politically that can be quite difficult to do, but we've seen, just like Jokowi did when he was governor of Jakarta, that people are prepared to have this debate about seeing the price of fuel rise if they get free health services. And we have seen this type of approach adopted by other countries too. My own country is going to have an election next year. It's highly likely that there's going to be a change of government, with a new government coming in that is going to be much more explicit about increasing taxation to improve the state of our national health service. Households are smart. They know how much they need and want health services. So I think there is a very good case for us to put to the presidential candidates that this would be a very smart policy to follow. And that were these reforms genuinely universal, so that everyone feels that they're benefiting from this, and it takes away the anxiety that if they get sick, they're going to fall into financial hardship, this would be very, very popular. And you'll tend to find at the moment that politicians are in the market for popular reforms. So this is one that I would very much recommend. So thank you very much indeed, and it's been an absolute honour and privilege to open up this fantastic conference, and very, very excited to be involved in the discussions about the white paper, which I think very much fits with this type of idea about universal coverage, primary healthcare focus, and could be a blueprint for a new health system here in Indonesia. Thank you very much, Steve. Thank you.
Thank you for your speech, Mr. Yates. Once again, please a warm round of applause for Mr. Robert Yates, Executive Director of the Center for Universal Health, Chatham House. Now, for the next one, His Excellency, Bapak Budiono, the 11th Vice President of the Republic of Indonesia, will be delivering his keynote speech through a video message.
Ladies and gentlemen, esteemed colleagues and fellow advocates for primary healthcare. The onslaught of COVID-19 and other health resilience issues, natural disasters, as well as armed conflicts in the past 2 years has brought unprecedented disruption in human lives across the world. Take one readily available general indicator. The Global Human Development Index has seen a consecutive 2-year decline from 2019 to 2021, nullifying the progress achieved in the previous 5 years, with over 90% of countries worldwide witnessing a downturn in their Human Development Index. One of the primary dimensions of Human Development Index, that is long and healthy life, assessed through the life expectancy indicator. Research by UNDP and Hofline indicates a severe drop in life expectancy from 92 years in 2019-2020 to 72 years in 2020 to 2021. This decline mirrors the current state of public health and underscores the severity of future health development challenges. Health equity, the principle that everyone deserves a fair opportunity for a healthy life, remain an elusive goal for the majority of countries. To achieve this, we must acknowledge the interconnectedness of health, economics, and other determinants. In the context of Indonesia, while remarkable strides have been made, we have now come to a critical juncture where we urgently need a fresh look at and a renewed commitment to the issues of health equity and all its important dimensions. The Ministry of Health has initiated transformative changes. Yet, the realm of public health often presents complexities beyond traditional boundaries. Challenges like isolating specific communities, budget constraints, bureaucratic hurdles, cultural barriers, and deep-seated political intricacies demand solutions that transcend one ministry's jurisdiction. This calls for embracing intersectorality, breaking down silos, and collaborating across sectors. Intersectorality also underscores the importance of engaging civil society perspective. Civil society organizations, with their dedication and grassroots connection, are pivotal in promoting participatory community engagement and ensuring social accountability. Active community involvement empowers individuals, making policy more responsive and services more accessible. It cultivates a health-conscious culture where individuals understand the interconnectedness of their well-being with that of their neighbors. Our gathering today, facilitated by civil society organizations, exemplifies our shared commitment to fostering health equity and economic prosperity. This meeting serves as a reminder of the indispensable role of inclusive governance involving our communities in shaping the health landscape, not only in Indonesia, but also across ASEAN and globally. As we reflect on these principles, we recognize that they remain constant, albeit on a broader scale, when we extend our vision beyond national boundaries to ASEAN and the global stage. It is through forums like this, enriched by civil society's constant flow of evidence, various reports, policy analysis, and recommendations, that we can transcend boundaries and work collaboratively toward a healthier and more equitable world. I wish everyone a successful convening in the coming 2 days.
A sincere thank you for Bapak Budiono, the 11th Vice President of the Republic of Indonesia. Before we proceed to the lounge, ladies and gentlemen, let us familiar ourselves a little bit with the team behind the white paper for the design of Indonesia's health sector development 2024-2034. The team is, of course, CISDI, Center for Indonesia Strategic Development Initiatives. For the past 9 years, they have shown great effort and master valuable experiences in strengthening the primary healthcare system across Indonesia. They have been doing this through grassroots interventions and policy advocacies. The initiatives range from technical assistance for local health offices to creating a meaningful community health workers engagement. And now, ladies and gentlemen, it is time for us to proceed to our main event for today. We invite you to the launch of the white paper for the design of Indonesia's health sector development 2024-2034.
Ini loh, Tef. Lu tuh greget gak sih lagi-lagi isu kesehatan lagi rame dibahasnya?
Iya ya, kenapa ya Rai? Kayak isu stunting, kurang gizi, obesitas, diabetes, kayak gak pernah selesai gitu dibahasnya.
Banyak banget yang lo mention, kayak Jakarta tuh angka stuntingnya masih tinggi. Terus lagi ada polusi udara yang bikin anak-anak ISPA.
Nah, belum lagi ngomongin yang lainnya, kayak layanannya, kepuasannya, lama.
Kita pasti sering bertanya, kenapa masalah kesehatan terus berulang? Seperti lingkaran yang tak berujung pangkal, masalah akan berputar dan terus berputar, tak ada hentinya. Kita mungkin merasa sudah merapikan masalah yang bertumpuk. Kita mungkin merasa sudah menatanya. Kemudian kita berpuas diri, seolah semua masalah sudah selesai. Tapi kalau kita lihat lebih seksama, melihat sekeliling, kita akan sadar bahwa masalah itu masih ada.
Lo sadar gak sih kalau kita tuh lagi ngadepin banyak banget masalah kesehatan?
Bener, Tef. Setelah pandemi COVID, ada TB, terus anak muda banyak yang sakit jantung, diabetes, kolesterol tinggi.
Nah, bayangin deh, angka harapan hidup kita tuh makin turun drastis, lebih kecil dari kayak Myanmar, Laos.
Akhirnya, kita tak tahu harus dari mana untuk menyelesaikannya.
Aduh, angka diabetes naik,
Obesitas naik,
kasus polio muncul,
prevalensi perokok anak naik.
kader kesehatan nggak digaji, ribet, banyak banget dah masalahnya.
Sebenarnya nih ya, persoalan sistem kesehatan di Indonesia tuh bisa diselesain.
Hah, emang gimana?
Banyak, salah satunya dengan kolaborasi.
Kita ingin segera menyelesaikan masalah yang berserakan. Kita terkadang abai pada proses. Kita juga sering lupa memilah masalah, bahkan tak jarang enggan mendengar masukan. Ada kawan yang mau mengulurkan tangannya untuk kita. Ada mereka yang bisa kita dengar. Ada mereka yang mengingatkan kalau kita salah. Ada yang bisa membantu kita memilah masalah. Ada mereka yang bersedia menemani kita. Kita harus yakin bahwa perubahan juga perbaikan tak bisa terjadi dalam satu malam. Dan kita pasti berpeluh untuk menata berbagai hal pada tempatnya. Tapi, semua ini akan sepadan dengan apa yang kita harapkan.
Intinya Rai, kalau kita mau berubah ke arah yang lebih baik, pasti ada jalan kok.
Betul banget, Tef. Semua perubahan itu dibutuhin untuk mewujudkan Indonesia yang sehat dan berkeadilan.
Good morning. Let me tell you a story about Mentari and Kasih Asih. About how they slowly lost their color. Kasih is a Puskesmas health worker located just a stone's throw away from Jakarta. She is often tasked to check on the conditions of the community to make sure that stunting numbers are kept low. She didn't know that this is now becomes her daily routine. During her morning visits, she stumbled upon a little girl whose name is Mentari, still in her primary school uniform, sitting alone in the front yard of her house. Kasih crouched down and asked Mentari why she's sitting alone. Mentari said she's hungry and have only eaten instant noodles for breakfast while it's 3 p.m. already. Kasih noticed in her hand was a box of sweetened milk that she probably got from the shack up front, or perhaps from her school. Kasih then asked Mentari where her parents are. She answered, saying her mother is a laundry worker and she's still up working in a neighbor's house. While COVID-19 cost her dad his job, and he's now working as an ojek driver, motorcycle hailing worker. Kasih decided to take this little girl to the puskesmas so she can eat and have a proper meal. As they were leaving out, she locked her gaze to the table in the middle of the living room in Mentari's house and noticed there are cigarette packets stacked one on top of the other. Of course, it's definitely not an easy problem for Kasih to face. The average family living in Kasih's work area mostly are informal blue-collar worker in the sector, alongside those who are vulnerable and near poor. As she tries to make little conversations with Mentari to loosen her up, Kasih thinks how she needs more support from her district government to do things like this. Yes, she was tasked by the government to reduce stunting, they said. But what can she actually do? And that's why taking Mentari for a proper lunch is the best thing she can do right now. Kasih strolls through the puskesmas hallway and she took Mentari's little hands in hers. Just like any other day, she passes the doors of the nutrition rooms, labor and delivery rooms, maternal, child, neonatal clinics, and the elderly clinics, all filled to the brim with people just wanting to be healthier. She dropped Mentari off in one of the small empty rooms, and then she tries to find something in the counseling service and some substantial food. But suddenly her coworker appeared out of nowhere and pleaded for her help. I have a patient that can't be left alone, while this data I have to work on is urgent, he said. And Kasih knows he is the only one out of the 25 workers in the puskesmas that can do the job. And Kasih also knows that this task is going to be taxing and time-consuming, and he won't have time to attend to other patients. 3, she counted. The number of different data applications just for this one single task. Wasn't there a data analyst here at one point? She wondered. What happened with that program? Could it be budget cuts once again, or is it a shift in the priorities of the puskesmas? Kasih just managed to nod to her coworker and tried to get Mentari out of there as fast as she could. On her way back to Mentari, she overheard a little commotion in the administration room, stopping her. It was then she saw an individual who doesn't have an ID number, desperately pleading to get treatment. It's known that many puskesmas facilities provide free services to those who do not possess IDs, or as we call it here, KTP. But it's often done out of discretion and compassion and feeling of pity and the goodwill of health workers like Kasih. Budget is always tight in the puskesmas, with programs and health workers being cut from the facilities. As Mentari stands waiting next to Kasih, attending to the commotion with the meal she got, Kasih's mind baffled on how this is just another regular day for her at puskesmas. The story of Kasih Asih is just a small glimpse of the challenges and realities faced by many health workers in the health system in Indonesia. Not to mention how the COVID pandemic worsened the health system and the pre-existing inequities beyond the health sector. From here, CISDI saw the pressing need to take the initiative to deep dive in the issues of providing an equal chance of living a healthy life for all. And so here we are today to launch the white paper of Indonesia's Health Sector Development 2024-2034. Before I begin with all the interesting data and findings and recommendations, I would like to thank the team who works behind this scene for a year. The white paper team, please stand up. Please, once more round of applause for the white paper team. Thank you. I love you, and I'm so proud of you. This white paper has gone through 21 Delphi sessions, 4 plenary sessions with 154 expert resource persons from both health and non-health sectors. I see many familiar faces that we met in Zoom meetings and in plenary meetings, and on behalf of the team, I would like to thank all the expert resource persons who ever so kindly sat with us in the hours and hours where we dig deep into unearthing data in the health sector development. We then perform horizon scanning. This is corresponding to the foresight methodology that we're using, where we compile opinion articles and mapped out a network analysis based on trends, frequency, topics that have risen from the period of 2017 to 2023. We opted for compilation of opinion articles because previously CISDI has also done 3 to 4 times discourse network analysis, social network analysis through public discourse from Twitter conversations, but since Twitter moved from Twitter to X, they closed the access for researchers to mine the data of conversation. So we had to move and compile the opinion articles instead. Key actors and issues were mapped and identified, and the notable key events that come up in 2017 are BPJS Kesehatan, that's the health BPJS, the National Health Insurance, and BPJS Ketenagakerjaan, which is also an insurance but for labor market. In 2018, National Health Insurance, BPJS Kesehatan, and tobacco. 2019, National Health Insurance come up again, COVID-19 and face masks, the last two, because I think in 2019, COVID has started going into public conversation. In 2020, the COVID-19 dominates public conversation. 2021, COVID-19 and vaccines. And 2022, WHO, COVID-19, and I would like to note that Community Health Center made their appearance in after 25 years, so after 5 years. In 2023, WHO, MOH, COVID-19 came up to public conversations again. Then we do connect the dots. We connect the dots to showcase the interrelations between actors and events. And I would like to draw your attention into the note on my right-hand side on the far end, which is the Riskesdas. Riskesdas is the basic health survey. This note, for some reason, is the only note not connected to COVID-19. Analysis of why is in the main book and in the 12 other books that is now up on our website that you can download. On some of the tables you have the governance and the main book for you to read. Most frequent relations with MOH, Jokowi, BPJSK, that's kesehatan, that's health, and central government. And then also relations between actors and issues on vaccine siloed and exclusive to COVID-19 nodes. So when people talk about vaccines, they only connect it to COVID-19, while actually there are other vaccines and other immunization programs, but it never came up until COVID vaccine. The notable events are, and actors also, is the legislation at subnational level, that's DPRD, DPR, that's Parliament, at national level, JKN, that's the health insurance, and APBN, which is the state funding, state budget. From this point, after we connect the dots, we mine public conversation, we mine the data, we expand the horizon as best we could, so we can then identify and classify, categorize the horizon, the things that we found in the horizons, in events, trends, and drivers, into structural challenges. There are 4 structural challenges that we identified, and it's governance, financing, systems, and people. We use a certain framework, which is the GPMB framework, which interestingly overlaps between health security, pandemic preparedness and response with the health system and health impact in general. With utilizing this framework, we pinpoint, first one is governance. We pinpoint 3 important points under this category of governance. Is the dynamics in cross-sectoral collaboration. We see lack of intersectoral collaboration. We see organization and program overlap between government, public, state, institution. Sometimes multiple programs overlap in one or in other institutions. We also see a growing trend on consultancy dependency. This is very interesting because state institutions becomes more heavily reliant on consulting. And consultants, instead of do a supporting and facilitating role, slowly but steadily become the center of policy making and policy processes. Financing, the second structural challenge that we identified 3 points under financing, which is limited investments in health sector in general, but also health system in particular. Weak results-oriented budgeting, underutilization of innovative financing in the revenue collection measures. And I would like also to point out that the recent enactment of the health law limits investment in health and health system further by the deletion of the mandatory spending. Structural challenge number 3, system. Of course, we see system fragmentation. One state institution design that implement its own system without regard to the whole or the continuity of the whole other cross-government institutions and also the innovations and initiatives from non-state actors. This is shows a potential of duplication and misalignment, cause ineffective policy synchronization, and also we identify the tendency towards top-down nature of bureaucracy. So it's not a two-way or bottom-up, but most policy is done top-down in nature. Number 4 is people. Inadequate, meaningful community participation, inequitable access for vulnerable groups, inequities toward women and gender diverse population, and there is a growing lack of autonomy and health decision-making power among women from individual to state level. This is very concerning because the health system is supposed to be people-centered, and it's supposed to be on the side of vulnerable populations, namely women, children, and vulnerable populations. Now, with all that seemingly pessimistic findings that we have, we try to develop 4 plausible scenarios on where we see that the axis, X and Y axis, are outside of health, actually. It's governance and value principle. We identify 4 plausible scenarios. I will not go through all 4. They are explained in detail in your main book. I will just go to the worst and the best plausible scenario. Worst scenario is low quality, the characteristic is low quality governance and wealth-oriented accumulation. So accumulation of wealth. We call this scenario red flag. It shows weak delivery capacity, non-inclusive governance, unaware of people's rights to health, and focus only on the accumulation of wealth within the health sector, while health is the global public good, and accumulation of wealth should not be the sole purpose or the sole driver for public health and health policy making. The best case scenario is value-based and high-quality governance. We name this one green flags. If this scenario is in effect, then we are on the right track to achieve health equity. We will have robust primary healthcare investment. We will have people-centered health system, and there will a sustained platform of meaningful engagement and inclusion of non-state actors, including the academia, the private sector, the think tanks, civil society, and wider communities. We offer the reproduction of the Ullman framework, where we combine this to be people-centered. The population is the heart of the next intervention of this next 10 years. We take note that global health can no longer be detached from the dynamics at the national and subnational level, at policy level making, but also a certain influence and learning that can be done, that can be derived from global health to national, but also not one way, but two way, what the global health can learn from interventions and successes and failures and setbacks that we experience in Indonesia. But to achieve that, we have to make note that governance needs to be reformed, revamped. Health system governance needs to make sure that it's a singular system of 6 independent groups inside. So human resources for health, research, risk communication, financing, infrastructure must work in coherence as a system. There cannot be an overlap. If that system is done and is successful, it will ensure service delivery is up to the quality that we would like it to be. Outcomes and goals of public health targets and goals can be achieved. However, all those ecosystem of health cannot stand alone. We understood and understand and would like to also advocate that health is never alone. Health is interconnected with other development sectors. That's why we put in social, technology, economic, environment, politics, and value as the biggest influencers to health. Because whatever policy is generated from health, it will impact all the STEEP fees, STEE, P, and fee, and vice versa. But so what? If we have a framework, we identify the structural challenges, do we stop there? The team, this white paper, push further so we can let you know about the how. The white paper recommends delivery of 5 structural shifts. Indonesia Health Assembly, people-centered health system, investing in health system, integrative diplomacy in global health, achieving decent jobs for human resources for health. Those are the 5 structural shifts that needs to happen, that must happen, if we want a well-designed and well-structured health sector development for Indonesia for the next 10 years. Let's visit each of that 5 structural shifts one by one. One is Indonesia Health Assembly. Indonesia Health Assembly is actually a process, but a process made and designed based on impact, principles of impact, principles of delivery, clear target monitoring, clear risk mitigation, and clear indicators of achievements. This include, we propose what we call a loop, the loop. While as opposed to approaching 3 levels of governments hierarchically, we put it in a loop like a bicycle chain. So if one chain is broken, that the other two cannot work very well. And we include multiple actors in it. This will ensure coherence in Indonesia's position in health direction, the policy formulation process, the delivery process, everything will then be certain if this process is employed, with the caveat that it has to be impact-based and it has to be monitored very closely with an oversight and monitoring indicators. It cannot be just done based on to fulfill administrative duty because it's on the budget already. Second one is people-centered health system. We address 6 deliverables in this health system where leadership and governance encompass the framework with health and well-being for all as the outcome. This considers the 6 elements of STEEP fee factors and its impact on approach. These health systems, once implemented, will ensure primary health care, secondary care, tertiary care are all reformed thoroughly, not just at superficial level. The third element is investing in health system. We would like, of course, to raise enough revenues so individuals can be provided with health service package that assures health and financial protection against catastrophic illness in an equitable, efficient, financially sustainable manner. Second, the management of revenues through equity lens. And the third proposition is to ensure that payment or purchase of health services is carried out in allocative and technically efficient ways. We would also connect this investing in health system into the health system framework, because we need a well-resourced health system that will ensure we have a healthy macroeconomic growth and a sustained macroeconomic growth in the future. Integrative diplomacy in global health. We push for the adoption of the integrative diplomacy in global health that considers interrelation between domestic and global health issues. Like what I pointed out earlier, it's two ways. Not only what we take whatever in global health and implement here, but also the other way around. We give our insight, expertise, opinion, direction, preference, and national direction of our country, but can also represent the region, because Indonesia is geopolitically strong in that sense. It stressed how Indonesia can actively place itself in leading agenda-setting processes. And we can put the national agenda and the Global South agenda into diplomatic action. Achieving decent jobs for human resources for health. We know that human resources in health is very important, a critical element in the health system, but we also know that the damage, the losses that we experienced during COVID and even before and also now, which impacted human resources for health. Therefore, a full reform in how we see, perceive, and treat and issue policies for human resource for health must be done. We ask for a holistic end-to-end approach that puts health workers' well-being at the center of policymaking and priority setting. It established wage fairness based on merit among healthcare professionals, including the community health workers, and establish multi-level regulations on financial and non-financial incentive, in particular for the community health workers, with the mindset that the direction for the next 10 years, at least, of the Indonesia's health development sector must be directed to the vulnerable population groups. Okay, now let's go back to Kasih and Mentari. We see them every day, but we never realize that their lives are shaped by the structural challenge that were just presented. The delivery of the shift as means to achieve outcomes of the proposed framework is just our small patriotic call to realize a healthy, equal, and just Indonesia for all the Kasihs and the Mentaris out there. I thank you.
Ladies and gentlemen, a warm round of applause once again for Ibu Diah Satyani Saminarsi, founder and CEO of CISDI and principal investigator for the white paper for the design of Indonesia's health sector development 2024-2034. And thank you so much for the presentation, Ibu Diah. The story of Kasih and Mentari definitely resonates with the existing situation and our personal experiences. I would like also to appreciate the work of the white paper team that is able to produce thoughtful recommendations that are based on rigorous analysis. If you wish to access all 13 of the white paper documents, you can access it through the QR code and direct links you see on the screen as well as on the table in front of you, ladies and gentlemen. On this webpage, you are also going to be able to access CISDI's website and access the Q&A page and feedback form for the white paper. Later on, we will open a Q&A session, and we will select several questions to be answered by the panel and the writer team. Any questions you may have regarding the white paper, ladies and gentlemen, either for the author team or the panelists of the discussion, please do scan the QR code or enter the link to the browser and click the Ask a Question button. Okay, I think we are ready for our next session. Yes, and now we will listen to the comments from selected experts with various backgrounds. Through this discussion, we invite all speakers to highlight several key messages of the white paper. I would like now to invite the panelists to come up on stage. Dr. Abdul Malik, Minister of State for Gender, Family and Social Services, the President's Office of the Republic of Maldives. Good morning, Your Excellencies. Thank you. Please have your seat. And then Dr. Yodi Mahendra Datta, Dean of Faculty of Medicine, Public Health and Nursing, University of Gajah Mada. Selamat pagi, Pak Yodi. Please take your seat. And then Professor Kent Hughes, Director of Global Healthier Societies, the George Institute for Global Health. Good morning, sir. Next, Professor Herawati Sudoyo, Chair of the Medical Science Commission, Indonesia Academy of Sciences, IP. Selamat pagi, Bu Hera. And then Ibu Diah Satyani Saminarsi, Founder and CEO of CISDI. Last but not least, Dr. Karen Brown, Senior Fellow, Global Economy and Development, Brookings Institution, who is participating online from Washington, D.C. Can Dr. Brown already hear us? Let me just check for a bit.
I can hear you.
Oh,
I hope
thank
you.
you.
Can hear me.
Oh, it must be very late in Washington, D.C. currently.
It is.
It is, okay. Let us now just start with the discussion. A friendly reminder for everyone that this panel will resemble a talk show where I will ask questions and each speakers will have around 7 minutes. 7 minutes, we are on a tight schedule, to share their views and key messages. Following the panel discussion, ladies and gentlemen, there will be a Q&A session for participants. So make sure you scan your QR code or access the link that is available in front of you on your table. You can definitely share your thoughts as well as give your questions either to the panelists or to Ibu Diah as a part of CISDI, the team behind the white paper. Okay. Thank you very much for being here. This is such an honor for me. And on behalf of CISDI, again, thank you so much. Let's open the panel discussion by first asking Dr. Yodi. Pak Yodi, I understand that you are keeping track of Indonesia's healthcare and published your own report of Indonesia's 2017 Health Sector Review. What notable progress and challenges can be highlighted from then on until today? Are these challenges still persisting from 2017 until now?
Okay, so there is a short answer and there's a long answer to that question.
Let's go for the shorter one first. You only have 7 minutes, sir.
The short answer one to the top 3 challenges which persist until now, I would say number 1, inequity. Number 2, inequity. Number 3, inequity.
Okay.
Those would be the top 3. So that's the short, direct answer to the comparison to the 2017 review which we wrote, which is of course, it doesn't give it the justice because for the 2017 report, it took us 3 years to write and it's 300 pages. So I don't want to give you a 300 pages answer. So, but anyhow, beyond the top 3, in terms of progresses, of course, if you look back into the 2007 report, there are a lot of progresses, high level, especially if you look at into the classic indicators of life expectancy, under 5 mortality, infant mortality. There are progress of that. It has been improving in the past years, at least at the national level. There are still concerns, of course, in terms of maternal mortality ratio, for example. which is still, Indonesia is among the highest in Southeast Asia. Of course, the figure is still debatable, but I think everyone agrees that we are among the highest in Southeast Asia. In terms of communicable disease, TB is still a major problem. We are still number 2 in the world. The global TB report was just released 5 days ago, and we're still number 2 in the world, and still many TB patients undetected. Non-communicable disease, I don't think I need to say much. It's becoming increasingly important and also contributing most of the global burden of disease in Indonesia, increasingly even in the BOD IHME report recently, we can see that. And very little, I can say, progress in terms, especially in terms of mental health. But the one which I'm most perplexed on is that there is hardly anything which has been done in terms of climate change and health, then and even now. There is hardly anything we can see in terms of that. We tried to push it for several years now through National Academy of Science with Professor Hera, through G20, but there is not much progress up to now in terms of climate change and health. So I think that's the main one in terms of the high level and national level. But coming back to the issue of inequity, all of those figures mask the inequities in Indonesia because those are aggregate national level figures. Yes, there's increase of life expectancy. Yes, there is an improvement in terms of under 5 infant mortality. But if you break it down at the sub-national level, you will see disparity across socioeconomic, but also across the regions, as has been highlighted also in this white paper. So, and also in terms of the access to services supplied and so forth. So all of that, again, comes back to that issue of inequity.
Okay, Pak Yodi, but to what extent has Indonesia's policy reform, if you see one, responded to the structural challenges presented in the review? What were the best practices and barriers that you can identify?
Yeah, of course it has been challenging because between 2017 and 2023 we have 3 years of pandemic. So it's a bit difficult to expect much with that 3 years of disruption in between because there were reforms planned, there were policies planned, but we were disrupted for 3 years. So there is not much in terms of that 3 years besides we tried to cope with the COVID-19 pandemic. But if we're looking for some of the policies or some of the progress in terms of the response, I would say that there is much better appreciation of data for decision making, for policy making, and this has been very much thrusted by the COVID-19 pandemic. I remember the first time when on the first month that the COVID cases was announced in Jakarta, we were asked by the ministries, by governments, by ministers, to give advice whether we should lock down Jakarta or not. And we had difficulty because there was hardly any data to base that recommendation on. But after that, then we see a lot of improvement in terms of data, a lot of improvement of data analytic, big data, and so forth. And now also in the ministry, we see much more appreciation of the use of data, evidence for decision making. So I think that that's one good practice, which I really appreciate. The other one is what Ibu Dia was highlighting in terms of global diplomacy. We see that also strengthened in the past few years. Indonesia's contribution to global health. I've just returned from Geneva last week for the intergovernmental negotiating body for the pandemic treaty. And the presence of the Indonesian delegation there is very strong, it's very prominent, it's very much appreciated. Shared a lot of the insights from the South, as Budia was highlighting it. And also we saw from the G20, from the Asian Forum. So there's a lot of progress there in terms of the global health diplomacy. I think those would be the main two I would highlight.
Okay, thank you so much. You were talking about data. I would like to later confirm this with Ibu Hera. Later, Bu. Okay, thank you, Professor Yodi, for setting up the scene. Now let's move to Dr. Abdul Malik, the Minister of Gender, Family and Social Services of the Republic of Indonesia. It's such an honor, sir, to have you here. Thank you so much for coming.
Republic of Maldives.
Republic of Maldives. Oh my God. It's not even daytime yet, and I've already made mistakes. I'm so sorry for that. Okay, now it's such an honor to have you here. That's a for sure, because this means that we can compare notes on what's happening in both of our countries. I understand that maybe for some of you, some people might say that size-wise, our country cannot be compared to yours. But we might still learn a thing or two about your approach to healthcare as an archipelagic state. We might learn a thing or two as Indonesia is a large archipelago itself. So I would like to touch on the topic of a whole of society approach for an inclusive and accountable health system reform. What can Indonesia learn from your work in your country in relation to the implementation of a whole of society approach in facilitating our national health system reform?
Thank you. Very good morning. Assalamu alaikum. And I thank Chisti for inviting me. Thank you. When it comes to comparing notes, I will start with one word: decentralization. Our health system and all our systems were run in a very centralized manner through the central government in the capital. But then later, within the past 5-10 years, this change came about in decentralization, decentralized governance, forming island councils at every single island level. Even the smallest, like 1 kilometer by 1 kilometer island with 200 population will have their own island council. Mm-hmm. Additionally, they will have their small island health center. So decentralized health system with decentralized governance was the initial step. Then came the primary healthcare component. We had a very strong and successful primary healthcare setup back like 50, 60 years ago when we embarked in preventing vaccine-preventable and communicable diseases when WHO first came in and supported us. This was done through family health workers, community health workers within the island who were trained at basic level.
Okay.
But now that has changed. Doctors have come, specialists have come, nursing, all healthcare professionals have come in. So these family health workers, community health workers are not accepted as much. The maternity lady in the island is not supposed to deliver babies. They have to go to a center. So that shift has come about. But then through the very strong public health system back then, almost all our communicable diseases have come to an elimination stage. And the success is because it happened within the islands, by the island people. Now the challenge that we're facing is we have a very high non-communicable disease burden, where 85% of our mortality is due to non-communicable diseases like cancers, heart disease, stroke, diabetes, so forth. To tackle this, we are coming back to the primary healthcare model that we had before at island level. And we're going from both approaches, top-down and bottom-up. One is there's a very high-level political will. The president himself has appointed the vice president to chair the social council at the president's office, where there is a separate health committee with multi-stakeholder ministries, including Ministry of Transport, for example, or Ministry of Environment, in our case, which is very important. Ministry of Islamic Affairs sits there. Youth and Sports sits there. So it's whole of government to start with. And then whole of society comes when we had formed community social groups in the islands where the government stakeholders in social sector and the NGO, CSO, plus very importantly, women development committees in the island, which is a subdivision of the island council themselves, take part in this community social group committee who lead island level healthcare and social sector related issues. So it comes from the top with high political will, then it comes from the bottom, grassroots, from the people, issues are solved within island level. Issues which are hard to deal at island level is taken up to atoll, regional, and then to central level. So decentralization, top-down, bottom-up, both, and then coming from the people within individual isolated islands. Thank you.
Okay, thank you so much. That part about decentralization, I might need to ask for a response from Ibu Diah later on to just compare notes, what's happening in Maldives and in Indonesia, and then regarding the political will, Professor Kent Hughes will have his response later. But let me ask you another question, Dr. Malik. The role of civil society organizations, or precisely what can civil society organizations and women's group play in supporting Indonesia's structural and advocacy mechanisms to ensure that there is an accountability and inclusivity, because it is needed to strengthen the government's health system reform efforts?
Thank you. We do have a very strong civil society presence in the Maldives.
Yeah.
But mostly it is for youth and sports and other activities. There are limited health-related civil society groups which are more national level, centrally based. For example, the Diabetes Society, the Cancer Society, the Maldives NCD Alliance, and other professional bodies like the Maldivian Medical Association, Nursing Association, etc. We do count them as part of civil society somehow. Okay. But then these separate civil society organizations run their activities across the country. And their biggest role is a lot of policy advocacy, bringing what's from ground level, from island level, to the policy tables. For one example that I would take in Maldives, which was a very big success, that Maldives NCT Alliance, jointly with Maldivian Medical Association, led a campaign on pushing the government to impose graphic health warnings on all tobacco products.
Okay.
This happened in 2019. And then this whole process was led by, the white paper was written by, and the meetings were held all through the civil society process, brought to the president, met with the president, and also pushed the people's perspective by running campaigns that this change will happen, so as to making it easier for the government, for the resistance by public,
okay,
and by the industry itself, because we're talking about tobacco.
Yep.
Yeah,
yep.
so it
we
was
have that as well
hard
here.
for the government to just say yes to 70% pictorial warnings on all cigarette packets and other tobacco products. But then this president, he made the bold move. And now within Asia, not counting Nepal, I think in South Asia, we have the highest percentage of graphic health warning coverage on tobacco products. This was led by, basically purely by civil society.
Okay.
Yeah. And another thing, when you mention women groups and especially women decision making in these processes, when the Decentralization Act came, it was like any other act that anybody can contest and become an island council member. But later on, we brought an amendment where 33% of all island councils will have to be women. So now by law, there is given seats for women, which is 33% minimum. And they can have more. Yeah, and this is where it started. And additionally, there's this annex wing of Women Development Committee, which runs hand in hand with the Island Development Committee.
Okay.
So they lead all campaigns, which is social-related campaigns. One example, the WDCs run a campaign with the Ministry of Gender Social Services, which is called Geweshigulum, which translates to family bonds, where they address things like domestic violence, poverty, nutrition deficiencies, and other health and social related issues at family level. So that's where women organizations have a key role. Another area where a lot of civil society is strong is with use of data and doing research in their own sectors. For example, the Cancer Society doing the cancer prevalence studies, the maintaining the cancer registry with the Health Ministry. Similar to this, the Diabetes Society doing their own research. So this actually is adjunct to what the Ministry of Health has to do and is mandated to do, but then civil society plays a big role in being a partner.
Okay.
Thank you.
Oh, thank you so much. Please give a warm applause for Dr. Malik here. One thing that I would like to highlight from what you have just said, that it is important to actually to have a very strong coordination, a very strong cooperation between the government and civil society as well as women's group. Because some of the times when you don't listen to the civil society, when you don't listen to the groups, the grassroots groups, we will have a disconnect between what the people actually needs and what the government's policy is being produced. Okay, thank you so much for that. And right now, I would like to zone in on gender-related issues. So, Dr. Karen Brown, I would like to ask for your inputs here. So, intersectional factors is becoming more prominent in the conversation regarding healthcare system, with examples including socioeconomic status, climate change, and as well as ethnicity. So we don't have just like one focus in terms of approaching the healthcare system. We need to have an intersectional lens to see that. So how do you think can Indonesia integrate an intersectional lens into its healthcare policies to address disparities related to gender, ethnicity, socioeconomic status in its national health system reform?
Well, thank you so much. And I'm sorry I cannot be there in person, but I'm really delighted to be with you virtually. And I want to congratulate Sisti on the white paper. I think it resonates quite a bit. Let me start by saying that gender is a social system that defines men and women as different and distributes power and resources and status on the basis of these differences. And many people who work in this field think that gender system, which is this collection of norms, they could be equitable. But in fact, most countries or around the world do ascribe greater value to men and things considered to be masculine than to women, or things considered to be feminine. But I have to say that males and females, as you just have noted, are really not homogeneous. They're distinguished by differences in income or ethnicity or caste or geography or other characteristics. And this is the term intersectionality. It's a framework for understanding how multiple sources of power and disadvantage interact, and the pathways through which this can influence behaviors and practices and outcomes. And while there's more attention now to the policy implications of gender norms and to intersectionality, actual policies all too often continue to treat each type of disadvantage as an independent and separable process. But when you talk about individual people, it's very hard to separate these various characteristics. And multiple axes of power and socioeconomic inequality don't always work together in simple additive ways. And I think the research literature and experience shows that the gendered and intersectional hierarchies of power and privilege are manifest in many ways in terms of differences in health exposure, due to differences in women's and men's economic roles and the activities that they participate in, differences in health behaviors, for instance, norms of masculinity or femininity, which may involve differences in risk-taking or risk preferences. These differences in access to power and norms also are characterized in the ways in which people access care. For instance, research shows that in many low-income households, cost concerns may prohibit women more than men from accessing care, or they resort to informal care. These hierarchies of power and privilege also are manifest in the functioning of the health system. And I have to say, I loved Dia's story here. It was so illustrative. In many health systems around the world, there's occupational segregation. Women are not in the decision-making positions, but like in Indonesia, they may be an overwhelming part of the workforce, but they're the community health workers. They may be considered volunteer. There are gender wage gaps, particularly in different parts of the profession. But there's also the fact that women may receive inferior care relative to men, and they may be screened for disease less often. And of course, there's very strong inequalities in health research and data collection. And I don't know how many of you have read the book by Caroline Criado Perez called Invisible Women, but it's a really telling story of invisibility of women's concerns relative to men's in all of these aspects of health functioning. And I just have two more comments that are actually related to the invisibility. And I would be remiss if I didn't mention the recognition there's not a lot of recognition of the role of unpaid care, which is largely performed by women in the home, in families, in the community, which really substitutes for deficient health systems and for cost pressures in health systems when patients are discharged early or when there's not enough money to pay for formal care. Many women substitute their own labor for caring for formal systems. And I have to say the pandemic showed us that care is a deficit around the world, and governments haven't supported it. And as we think about healthcare reform, we need to think through a more coherent system for providing care, particularly for linking the unpaid caregivers. And I'm so happy our first panelist mentioned climate change, because climate change will only increase the needs for care. There's growing evidence in climate and health research that has linked changes in the ecosystem globally to the increased rate and incidence of air, water, and insect-borne infectious diseases. And here we have to think through how the burdens of care will be more equally distributed with slow onset climate change as well as sudden and extreme disasters.
Okay, Dr. Brown, 1 minute. I just need a short comment from you. So when we talk about intersectional lens, definitely it's going to be different from one country to another, especially Indonesia with its own problems. But what methodologies, what tools do you think Indonesia can employ to generate localized evidence and then ensuring that the policy decisions is going to be tailored exactly to the nation's specific needs, underlining the whole intersectional factors that are in play in Indonesian society?
Well, I think the first thing is that policymakers and program implementers need to actually recognize and acknowledge the existence of intersectionality as a key barrier to policy success. So recognition is first key. And that includes recognition that exclusion and inequitable outcomes occur both across households, but also within them, between men and women within households, as well as by age and other characteristics. And then I also think it means we need to have better data collection, and I'm so happy that others have mentioned that.
Yeah.
We need sex disaggregated and age disaggregated and other
and structures interact and what stakeholders say about the reforms needed to improve this interaction. So those kind of things that I think becoming, it's something that we want to have in Indonesia, a good ecosystem to support the research and knowledge. So we have what kind of issue that involve in this kind of development? Knowledge enablers. So it's regulatory authorities, it's a public and private bodies, knowledge users. Who is going to use that? Policymakers, a government, knowledge producers. That's universities, research institution, think tank. And intermediaries, of course, that's kind of like association, professional association, and don't forget the media.
Yeah.
Okay. So the Indonesian Academy of Sciences, which is an eagle eye of science and technology development in Indonesia, developing a study with the support from USAID, conducted evidence summit on reducing maternal and neonatal mortality in Indonesia. This is very important, applying and developing a global evidence summit. So it's not only about Indonesia, but about how Indonesia also can deliver result that can be used for all of us, actually. This study produces trusted guidance on evidence within the scope of 6 determinant areas, which I'm not going to do that. But the important thing is that the shift from evidence-based health policy approach to evidence-informed policy making.
Okay.
This is the process of translating evidence and information into advice and recommendation for policy making, and stakeholder engagement as process key and strategic activity in Indonesia. Furthermore, in 2021, this is with CISD, IP collaborate to conduct a study and publish a report entitled Foresight to Structuring and the Future of Indonesia's Primary Healthcare. This is why we also here to participate in this very, very important meeting. Dia already mentioned about it, that it carried out with the aim of providing recommended policy direction for the government and as a reference for other stakeholders using foresight methodology. And I think, in my opinion, some of them, or maybe all of them, is actually being used as a guidance by the Indonesian government. So applause to Dia. Safety.
Okay, so for all of you who are not yet informed, CISD, is it last year?
2 years.
2 years ago, actually published a foresight for the Indonesian primary healthcare system. Is it not? Yes. So yeah, I hope that there are more and more reports like this which can be used for the evidence-informed policymaking. Yeah, Bu?
Yeah.
Okay.
Bagus.
So I think Dr. Brown is reconnected with us.
I'm so sorry.
I am not able to hear her voice.
Can you hear me?
Okay, let's try to reconnect both the video and the audio with Dr. Brown. But then I will move on first to Ibu Dia. Okay, so Ibu Dia, the thing about, okay, let's try again with Dr. Ground. Is it already connected? GCD team.
Can you hear me?
Can you hear me? Yes, so she can hear us, but we cannot hear Dr. Ground. Okay, we'll try that one more time. Okay, let's move on to Ibu Dia. So, Ibu Dia, regarding the few discussions that we have already been talking about currently, the importance of a whole of society approach, the importance of civil society, the importance of women's group in play with what Professor Hera called evidence-informed policy making. Where do we stand now?
Going back to the 4 plausible scenarios that we designed and we wrote in the book, we are somewhere between, I think, the status quo spectrum, where it's titled, "Good intentions are not enough," and the red flag. The red flag is, of course, a spectrum that we all should avoid at all costs, because it's going to be very difficult to break out from that spectrum. The road to overall reform will clear up.
Okay.
That's the what we think is our current situation.
Okay, so you were talking about spectrum. It is definitely going to be a lot more difficult to actually measure what the spectrum is and whether or not we have already inching towards the green flags. So I have a quite big question for you. What do you think are the strategies, 1, indicators, 2, and then measurements needed to operationalize a people-centered approach in Indonesia's health system reform efforts, if you think that the whole spectrum is in itself a little bit difficult to define?
Well, we talk about delivery in this paper, one whole chapter of delivery, because it takes more than just sound policy making into for a program or a reform to be successfully claimed. In delivery, I think when we talk about delivery as a science in itself, one of the key preconditions are indicators, goals, and targets. For the health system, so it needs to be measured. So when we say we have successfully delivered transformation of primary health care, that needs to have measurement. One of the most important, I think there are many, again, in the book, there is, in every book, in health system book, you can find the annex where we laid out in detail the goals, targets, and indicators. But I would like to draw attention to the investment in primary health care and data. Those two are the most important targets and indicators that we must achieve, because right now, relating it to the investment, the health investment section, the financing section of this white paper, it talks about how difficult it is to invest in health system. While at the same time, in the health system book, we talk about investment as a key indicator towards success. So that's why a special session tomorrow on investing in primary health care is going to be discussed, because then we need to find innovative financing, whether it's through debt swaps, through increasing the excise tax of tobacco and sugar-sweetened beverage, and other innovative financing mechanism where we can then concretely achieve delivery in transforming our health system.
Okay, before I move on, but where do you think local context as well as community perspective where is it in the level of importance and in our need to actually reform the healthcare system in Indonesia?
It's of the utmost importance. It's the center of why we convene, why there needs to be continuous reform, not only in the coming administration, but on the multiple administrations to come. Because in multiple administrations ago, health was never a priority in health.
Yeah.
So in development, I mean. So it's a very important key in that.
Okay.
And communities, first you have to ask, right? I mean, I always say, what do communities need? Because then when you understand their needs, then you can build a policy that will correspond to what they want to do. That goes both ways. If the policy does not match their needs, then they won't do it.
Okay.
Communities won't act upon it.
Okay, you were talking about the investment in primary healthcare. That definitely needs political will. And then Professor Hera also mentioned about data and evidence-informed policymaking. That is also political will. And then Dr. Malik earlier today said something about, well, it has to be with civil society and et cetera, because you have the tobacco company, you have the sugar company and stuff like that. It is, again, political will. So this is definitely a question for you, Professor Kent Buse. We know that you have worked extensively in the realm of health policy making processes, and you have seen the push and pull between politics and health in your book, Making Health Policy. It demonstrates the whole push and pull between politics and health and sees that policy is ultimately about power and politics. Now, what implications do you see in the white paper that is launched today in Indonesia's health policy going forward? As healthcare will always be influenced by politics and political will, do you think that it will ever gain any traction?
Well, first of all, thank you, Sophie. I'm not sure what the "it" refers to there in that question, but power and politics and health. Selamat pagi. Rob Yates talked about the privilege of being back in Indonesia and Jakarta after 10 years. I am privileged to be back here after 39 years.
Wow.
39 years ago, I came here on a cultural youth exchange. I was in a rural, remote village in Nusa Tenggara Timur on Flores. I spent 4 months there in a village without running water or electricity. And it fundamentally changed my life, changed what I studied, changed the person that I became. So I have a lot of gratitude to the country. So thank you very, very much. And let me join others in congratulating Ibu Dia and the CHISTI team for the very well-timed white paper. It's very strategic and it's very comprehensive, and that might be one of its problems, its comprehensiveness, but we can come back to that. But to your question, if I understood it correctly, I've got a simple answer, and then I've got a longer answer, and I'm probably going to end up in the middle somewhere.
Okay.
But the evidence that I've reviewed over the last 30 years and the experience I've had as a policy advisor suggests that even the most powerful visions for health, particularly the transformative visions, getting to the green flags that you want Indonesia to get through in the next 10 years, sadly, they rarely achieve their envisioned aims. I mean, I think it's good to reflect on that. It's really important to reflect on that. Pro-equity reform is challenging, it's difficult, because the system is primed to reinforce the status quo, including in health policy. I mean, that's very clear. We've seen that since Alma-Ata, where commitments were initially made to primary health care, but as Rob showed us this morning, progress is possible. So despite the elegant arguments your team has made in favor of PHC, experience suggests it's actually hard to do the tax reforms. It's actually hard to shift resources from tertiary institutions to the community. Despite the strong case you make and the case that our colleagues have made for intersectoral collaboration, working on the commercial, the environmental, the social determinants of health, the path of least resistance will be for biomedically oriented health system to focus on the healthcare infrastructure. In other words, to continue focusing on the illness industry. The private insurers, for example, that we heard about earlier today. In short, my argument is that business as usual typically serves the status quo. The dominant interests, they have written the rules of the game. And so transforming your vision to reality, Dia, will sadly often be ignored or met with resistance. But I think it's important, I want to say, I think it's important that you accept that. And if you do accept that as a starting point, then you'll accept that it's a struggle. It's a long-term struggle, you just mentioned that. And it's a struggle where progress is possible, and we know progress is possible. And it's great to be on a panel with a male Minister of Gender, and it's great the topics that the moderators introduced today around gender and intersectionality and equity, and the power that we need to disrupt to bring about the change. But based on my experience reading the literature and in my experiences being a political advisor, I just humbly want to make 5 suggestions. But very humbly, I'm in your hands, I'm in your country. And the first one is treat the reforms as a political project. The technical tinkering is important. You all have jobs to do that I can't do in that regard. But I think that you also need to regard the project as a deeply political one. And that means thinking about the perceptions, the positions, and the power of key stakeholders, and how you leverage power. There is power in communities, etc. And among all the reforms, I think you and your allies should prioritize a number of them. And we've heard some contenders today in terms of tax reform and financing linked to the environment. We heard about the fossil fuel subsidies, which really ought to end here and everywhere. But I think that those limited number of reforms should be selected according to a number of criteria, not least which are some low-hanging fruit and feasible, but probably more important than that, where do they align with the aims, or kind of align with the aims of powerful actors? Where can you find some win-wins if you tweak your objectives marginally with your eye on the bigger prize? Convening dialogues, I think, is a third one, and you've referred to that, Dia. And I don't see this as one-off policy dialogues, but as you suggested, ongoing dialogues with key stakeholders where you try to forge a national consensus around some key reforms, and that you work behind the scenes with like-minded individuals that you find in government. I have a colleague right beside me from government, and you find allies in civil society as people have met in academia, including one sitting in Washington, hopefully or be able to join us again soon, and particularly with civil society movements, and we know that they're around. So my fourth one merged from my third one, it seems like, but build advocacy coalitions of people who share values and share normative beliefs and who want to bring about the equity, and the equality of opportunity. And as I said, I think you'll find those individuals in various sectors, and you need the strengths and the talents and the networks that they bring about. And you'll find them in the political parties as well. And finally, you mentioned my textbook, Sophie. Thank you for the plug. It's in its 3rd edition. A lot more case studies from low and middle income countries. But the last chapter in that is about developing, and it's my 5th point, developing political strategies for prospectively, over time, managing those select number of reforms that you prioritize. And there are effective ways of doing that. And all this requires resources, and so I go back to my humble suggestions for prioritization. But it's also, as I said, about partnerships and coalitions, and bringing people together. So I think you can have traction. Progress is possible, but you have to think politically, you have to act politically. And so as I said, I think that works better. And you brought that, that was in your film this morning. It's about collaboration, isn't it? That was what the film was about. It's about cooperation and collaboration for shared political projects. So.
Okay. Okay, so one more minute for you, but this is a very timely question that I'm going to ask. So Indonesia will have our presidential election and basically like the general election next year. It's on February. What do you think of the strategies that Indonesians can employ so that all the presidential candidates are willingly focused on health issues in their political agendas, especially after a global crisis like COVID-19?
Well, I think, as Rob mentioned in the opening this morning, I'd be pretty surprised if any of those leading politicians didn't have health on their manifestos. I'm sure they all have health on their manifestos.
Yeah.
I think it's really a question, do they have health
Enough.
Equity? Well, enough.
Yeah.
But is it about health equity? Is it taking a gender-responsive lens? Is it taking intersectional lens? Is it about the hard financing reforms? It's really what do they have? And for that, I guess if I've got 30 seconds left, I'd make a plea for framing.
Okay.
That, I think it's really important, and it's been alluded to already. What are the images that we invoke? Dia finished with a frame around patriotism. And there have been a number of other frames that have been put forward. But basically, how do we appeal to people's values when we're trying to sell this kind of a project? And how do we go with prevailing values? How do we tweak them a little bit? The second is really from my colleague around the knowledge ecosystem that she spoke of. And I think that there's a couple of schools of thought really on the evidence to policy and how to get the white paper into the manifestos, which I guess is the link I'm trying to make. And there's a pretty good evidence around some strategies that these two different tribes, researchers and policymakers or decision makers, can take to enhance the probability of uptake. But I think that from a political economist perspective, it's probably useful again to go back to the advocacy coalition, and that we try to find our friends who are policymakers, and we bring them close to us and we involve them in our research, and we get them to move forward to make evidence-informed policy, as it were. That's
a sound strategy. Thank you so much, Professor Pius. And then we already have Dr. Karen Brown again with us. Can you hear me? Okay, so she can hear us, but again, we cannot hear her. Let's try for a few seconds. But Ibu Dia, can you like give a response from all the discussions that we are having with Dr. Malik, with Dr. Jody, with Professor Pius, with Professor Hera, and then as well as with Dr. Brown? Where are you going to take this white paper?
Onward and upward.
Okay, we need an applause for that. Okay.
Well, I think that's the short answer. I mean, that's the framing that Ken just mentioned. As researchers, we see it as our moral responsibility and patriotic call, if I can put it that way, to give ourselves into the sector that we live and breathe in. But realistically speaking, I hear you, Ken, that it's something that has more chance to fail than succeed. And I think in our 9 years of CISD, we have come to that realization and accepting that as part of what we do, as part of daily lives. But that's why we have an advocacy team, and that's why we take our time, we focus ourselves in building a very strong argument. So anytime we get thrown off from the advocacy, and anytime we feel down, because of the rejections and the failures, we can always go back to that strong argument that we build based on data and inputs. I'm glad that Prof. Yodi mentioned equity, because it's something that CISD has been, that's the DNA of CISD,
Okay.
equity. We see inequity as a major hazard towards, as a barrier, major barrier towards progress even. And it's growing wider, and it's always that health and economics are being pitted against each other while it's not. I think we are now in the position where we can do a trade-off or find a balance. It's no longer a zero-sum game. And this paper, on purpose, talks about intersectionality in a specific book, where we address it specifically under the sexual reproductive maternal neonatal children's health and nutrition, because that's where the intersectionalities are often missed. But also we put intersectionalities on climate, climate and health, like what Karen mentioned earlier. And also there is a major research, one book on research and development where we discuss about building an epistemic community, knowledge community that can really put forward evidence-informed policy making process.
Okay.
And I want to take this 10 seconds to thank Karen for your patience. And Karen and I were in the Bellagio Center in Rockefeller together, where I flew this white paper idea, and she was one of my early commentaries on the concept of that white paper. So, Karen, I made it here.
Okay, that's good. Okay, on that note, I would like to try again to connect with Dr. Karen Ground. Can you hear me, Dr. Ground?
I can hear you. Can you hear me?
We still can't hear you. Okay, let's move on first. We are going to have a Q&A session later, but right now I would like to invite two experts who are present in this forum to comment on both the white paper as well as our discussions here. So the first one is Ibu Irma Yunita, Assistant Director General for Acceleration Puskesmas Indonesia. Ibu Irma, can you raise your hand? Where are you, Ibu Irma? Oh, okay. Thank you, Ibu. And then also Ibu Gita Syahrani, Head of Secretariat, Lingkar Temu Kabupaten Lestari. There you are. Okay, so I will go to Ibu Gita first. So she's actually an old friend of mine, so it's not right to call her Ibu. Gita, I would like to inquire your thoughts on the push and pull between climate and health, as well as the externalities that may impact such health system reform. Can you share your thoughts with us?
Sure, thank you for the question, and also thank you so much for the distinguished panelists and the very insightful launch of today's white paper. So just as context, those of you who haven't heard of our organization's name is Lingkar Temu Kabupaten Lestari, or the Sustainable Districts Association, and we represent district government that are trying to find a balance between ecosystem protection and also economic development. So kind of what the paper alluded in terms of finding space in a very growth-oriented development pathway, not only for health, but for climate in general. Because for us, health becomes the bridge, the umbrella. Instead of talking about climate crisis on the ground at our districts are located in Kalimantan, in Sulawesi, and also in Sumatra. So the three islands that experience the highest disaster rate in terms of natural disaster. We talk about it from a health angle. So, for example, the push that I wanted to plea on behalf of the district members for the white paper, and also where this is taken forward, is to try to see the interconnectivity between the numbers. So, for example, Jakarta, one of the most polluted day in the past 3 months, our air quality reached to something on the verge of 252 AQU indexed. And that is a combination of factors between our energy choices.
Okay.
It was mentioned before in terms of the selection of fossil fuel, but also how we transport ourselves, how we travel. And in Riau province and in West Kalimantan province, in Riau back in 2015 when it was the biggest fire season, the air quality was 948. And Pontianak in West Kalimantan this year was the most polluted city in Indonesia during the fire season. And just because looking at that number showcased the equity conversation between how conversation is led between the national level and the subnational level. The subnational really feels on a day-to-day basis how natural disaster and not kind of connecting between climate issue, land use issue, energy choices issue, and health issue. It becomes something that means either they can maintain living or dying.
Okay.
So in that context, I want to quote one study in 2016 that was observing fire at that time. And it says that more than 100,000 deaths can be accumulated directly because of the fire. And another study in Jakarta this year that was saying that in terms of the way that the fossil fuel power plant planning grows, the amount of death and low birth weight per year will increase nearly double for Indonesia. So let's have that sit with us for a second and have that becomes part of the plea for the way that the white paper is being taken forward. And think also about the momentum. Our long-term development plan is ending in 2025, and this year and next year is a drafting year for the next 20 years at the national level and also at the subnational level. So how can intersectionality, the nexus between climate, land use, energy, health, becomes a priority, not only as a white paper here that is very well crafted, very well designed, and very well thought through in terms of process and inclusivity, also mirrors the way that we envision our 20-year scenario ahead. Because as the paper said, there is no 2045 Indonesia without a resilient community. Without the community itself considered as capital, as useful capital. And if we fail to recognize that connectivity, we also fail to build the opportunity to have high quality capital. One more thing to highlight is not only the disaster lens that is important for that nexus, but also the way that we consume. Stunting, for example, was one of the issues that is highlighted in the white paper very highly. And this is one of the number that was quoted as something that's preventing from the 2045 target for Indonesia to be achieved. And if we look at soil quality as something that can connect us all, regardless the sector, regardless the priority, I completely agree with the panel that says business as usual are usually the one that stays. But looking at this not also as a burden, but as an opportunity. Look at sectors like bioeconomy that allows us to look at biodiversity protection and soil quality assurance as part of Indonesia's economic going forward. We look at traditional knowledge, for example, looking at fishery sectors that is living in a healthy peat condition and are able to extract very important health supplement like albumin from protecting peat. So looking at bioeconomy as a sector for Indonesia as opportunities moving forward should also be in. And as a conclusion, Mbak Sophie, the bioeconomy is actually already in the current draft of long-term development plan of Indonesia. So I think the plea, the last plea would be, let's actually make that as one of the umbrella for us to push forward so that we see health sector, economic, as part of an economic push also for Indonesia, as part of an opportunity to grow, as part of an opportunity to value biodiversity, and hence connecting it back to the climate issue. Thank you.
Thank you, Gita, for reminding us how steep the struggle is going to be, but nonetheless, hope persists. Okay, Next, Ibu Irma Yunita have also participated in this event. Ibu Irma, I will ask Ibu Irma for her thoughts on the operational feasibility of such health system reform. Jadi Ibu Irma, apa pendapat Ibu tentang probabilitas operasional dari reformasi sistem kesehatan? Apa ini sebenarnya selaras nggak sih Bu dengan kebutuhan di lapangan?
Ya, baik, terima kasih. Thank you very much. First of all, I would like to say thank you for CISDI to invite me. Especially, I would like to introduce myself first. I am the Vice Secretary of Akselerasi Puskesmas Indonesia, or in short, sorry. Let me introduce myself. So I am actually the Vice Secretary of Akselerasi Puskesmas Indonesia, or Public Health Center in Indonesia, and we are as the association. And the name of our association is Puskesmas Acceleration, or Public Health Center Acceleration. Our organization built around 2 or 3 years ago, and our mission is to accelerate our puskesmas in Indonesia. As we know that puskesmas, or public health center, is actually the core business which really close into society. So that's why we coming here to deliver anything that is, maybe all of you come from any other countries, talking about primary healthcare, only theoretical, but let me saying something more operational or more technical in this forum.
Okay, that
Yes.
mounts an applause, ladies and gentlemen. Okay, please continue, Ibu.
Okay, maybe next I would like to say in Indonesia, I have translator, we have
Okay,
translator,
yes.
because it's actually more convenient for me
Sure.
to say my opinion in this big forum. Baiklah Bapak Ibu, terkait dengan bagaimana policy kebijakan yang saat ini diberikan terutama oleh Kementerian Kesehatan dengan kenyataan yang di lapangan, tentu kami Puskesmas sangat menyambut baik dengan adanya kebijakan transformasi pelayanan kesehatan dasar, terutama Puskesmas. Tentu banyak sekali tantangan, kalau bicara tantangan yang terjadi, yang kami hadapi. Tentu di sini Indonesia tidak lepas dari sebagai negara kepulauan yang terdiri dari wilayah terpencil, sangat terpencil, dan jangan dilupakan kita memiliki wilayah daerah kepulauan tertinggal seperti itu ya, atau disingkat dengan DPTK, dan puskesmas juga jumlahnya sangat banyak Bapak Ibu, 10.000 lebih, namun tentu itu sangat terbagi, ada yang terpencil, sangat terpencil seperti itu. Dan dengan transformasi kesehatan ini kami sangat berharap Kementerian Kesehatan dalam hal ini bisa menyesuaikan transformasi sesuai dengan kondisi dari setiap puskesmas yang ada. Yang paling utama saya rasa adalah mungkin di sini kita bisa mention Ministry of Finance ya Bapak Ibu. Di sini hadir mungkin ya. Kami dari puskesmas tentu menghadapi situasi yang mungkin dari sisi finansial itu tidak terlalu signifikan. Mungkin itu bahasa halusnya ya Ibu ya. Tidak terlalu signifikan karena dalam menjalankan program seperti kita ketahui puskesmas ini adalah pusat kesehatan masyarakat. So it's public health. So it's not about individual or it's not about curative only, but we have promotion, right? Tentu di sana biaya bicara pembiayaan di negara kita mungkin belum cukup merata pembiayaan untuk public health. Jadi kita masih concern terhadap upaya kuratif. Dan kita belum memiliki semacam insurance atau asuransi untuk pembiayaan public health. Saat ini jaminan kesehatan nasional kita itu masih mengarahnya kepada upaya kesehatan perorangan. Nah, itu yang pertama terkait dengan pembiayaan kesehatan yang mungkin kami sangat berharap besar dan saya yakin saat ini tim Bapak BGS juga sedang mengarah ke sana bahwa kita akan bertransformasi mengarah ke public health dan kembali ke kitohnya puskesmas adalah pusat kesehatan masyarakat begitu ya, bukan pusat kesehatan perorangan seperti itu. Ya. Tentu untuk menuju ke sana itu harus dibedakan di mana puskesmas saat ini dengan eranya JKN, mungkin BPJS Kesehatan juga hadir di sini. karena saya dulu juga pernah sebagai fungsional, saya seorang medical doctor, saya pernah sebagai fungsional yang bekerja di puskesmas. Sehari-hari saya bekerja, saya sibuk Ibu melayani pasien yang berobat, yang dalam arti mereka meminta rujukan ke layanan kesehatan lanjutan. Sehingga teman-teman di puskesmas ini tidak hanya sibuk di luar gedung, tapi di dalam gedung juga sangat sibuk. Karena banyak sekali pasien yang datang yang mungkin bisa dibilang mayoritas juga banyak yang minta rujukan gitu. Referral letter, ya kan, yang harusnya itu dibedakan layanan tersebut antara UKP, upaya kesehatan perorangan, dan upaya kesehatan masyarakat. Itu juga menjadi tantangan kedua. The second challenge is human resources, gitu. Jadi the first is financial, the second is human resources. Jadi kalau sumber daya manusia di puskesmas bisa menurut riset, saya yakin sini Bapak Ibu mungkin dari para akademisi atau adik-adik mahasiswa juga melakukan penelitian dan kami sangat welcome. We have big data in puskesmas, silahkan dilakukan riset sebanyak-banyaknya dan bisa dibilang ada, kalau menurut Permenkes 43 2019 yang mengatakan tentang SDM di puskesmas itu minimum ada 9 ya jenis tenaga kesehatan. Namun kenyataannya itu sulit seperti itu. Yang paling sedikit malah itu tenaga kesehatan masyarakatnya. Dan kebetulan juga di tesis saya pun, walaupun kemarin pada saat saya S2 itu hasil penelitian sangat sedikit yang mau bekerja di puskesmas begitu Bapak Ibu. Why? Kenapa? Karena memang karir, jenjang karir, kemudian juga secara kesejahteraan, teman-teman di puskesmas itu masih sangat minim. Dan itu sangat menjadi perhatian yang seharusnya sejak dulu kala oleh para pemimpin negeri ini. Karena puskesmas itu menjadi ujung tombak. Bagaimana teman-teman kita di puskesmas mau melayani dengan sepenuh hati jika kesejahteraan mereka saja tidak cukup. Nah itu menjadi sebuah isu menurut saya.
Baik.
Saya agak curcol sedikit nih, ini di luar konteks. Saya lulus waktu itu ya, Ibu boleh ya.
Silakan.
Saya lulus sebagai seorang GP, itu saya digaji, pada saat itu saya masih PTT statusnya. Mungkin tidak percaya yang di ruangan ini, tapi itu kenyataannya. Saya digaji hanya Rp1.500.000.
Oke, sebentar. Rp1.500.000.
Betul.
Itu kalau bagi yang tidak terlalu paham, itu kalau dikurskan jadi sekitar $100 ya?
Iya.
Ya.
Saat ini?
Ya, saat
Betul.
ini. Oke, silakan.
Saat ini,
dilanjutkan.
dan itu di tahun 2009. Jadi kurang lebih hampir 14 tahun yang lalu. It was 14 years ago, dan I only got 1.5 million. Dan itu dibayar hanya 3 bulan sekali, Ibu. Jadi saya bekerja 3 bulan, saya tidak mendapatkan gaji sama sekali. Seperti itu. Itu kondisi di puskesmas. Itu saya sebagai dokter. Teman-teman saya perawat, bidan, itu digaji hanya 300.000 per bulan. Itu tahun 2009. Dan kemarin kami dari Apkesmi melakukan survei kecil, short survei begitu di jejaring kami melalui WhatsApp group. Dan mereka ternyata masih ada beberapa daerah yang menggaji tenaga kesehatannya hanya di angka di bawah 500.000 begitu Ibu.
Baik.
Jadi itu suatu kondisi yang sangat menyedihkan sebenarnya.
Oke.
Dengan bisa dibandingkan pada saat itu saya fresh graduate, teman saya mohon maaf yang bekerja di institusi keuangan seperti itu ya Bu, yang saya sekolahnya mungkin 6 tahun, 7 tahun saya harus jaga malam dan sebagainya, saya digaji 1,5 juta. Teman saya bekerja di Bea Cukai D1, itu digaji fresh graduate 4 juta rupiah.
Oke.
Jadi sangat jauh ya Bapak Ibu.
Ini kalau di Twitter obrolannya pelan-pelan Pak Sopir. Oke, silakan dilanjutkan Bu.
Lanjut ya Ibu. Jadi itu dari sisi kesejahteraan. Jadi Bapak Ibu di forum ini saya ingin membuka mata hati Bapak Ibu semuanya. Bagaimana rekan-rekan kami, sahabat kami, tenaga kesehatan. Saya tidak bicara, kebetulan saya ASN di Jakarta Bapak Ibu. Kalau Jakarta mungkin tidak perlu saya sebut ya angkanya. Tapi saya pernah mengalami di 14 tahun yang lalu saat saya PTT di daerah. Dan itu tidak termasuk terpencil ya. Di wilayah Sumatera Selatan asal daerah saya. Apalagi teman-teman kita yang terpencil. Di daerah kepulauan, itu bayangkan. Jadi yang pertama tadi finansial, kedua human resources karena memang sangat masih minim. Kenapa banyak sekali SDM kita banyak Ibu, lulusan dokter banyak dan terakhir kalau tidak salah yang saya tahu masih ada 5% dokter, 5% puskesmas yang tidak ada dokter. Seperti itu.
Oke,
apalagi tenaga kesehatan lain.
Baik.
Ya, kemudian selain itu tentu adalah support dari local government, pemerintah daerah. Dan saya yakin pemerintah pusat tidak bisa bekerja full jika local government itu tidak full support.
Baik.
Dan itu terkait dengan APBD juga Ibu.
Oke.
Saya harapkan pemerintah pusat bisa mendorong pemerintah daerah agar mengalokasikan anggaran kesehatan lebih besar bagi puskesmas di wilayahnya. Demikian Bu.
Terima kasih Ibu Irma. Thank you Ibu Irma. Please give her a warm applause. That was a thorough fact check, actually, regarding the primary healthcare system in Indonesia and what actually people in grassroots are actually experiencing firsthand. Okay, so ladies and gentlemen, we actually have invited team leads or representatives from all three presidential campaigns in Indonesia that is going to run for the presidential election in February in 2024. I would like to see a raise of hands from all three campaigns. Camps, if you are here. Oh, there you go. So, we have invited all three. It is free for them, whether or not they are coming here or not. So, I would like to ask specific responses from either camp. I think we have only two representatives here from two presidential candidates, but I would like to ask for your input and whether or not you might think about adopting any kind of facts, any kind of analysis that we have put out in the white paper in your future campaign. Silakan, Bapak. Can you please introduce yourself?
Yeah, thank you. My name is Wijayanto Samirin. I am representing Anis and Mohaimin Iskandar camp.
Okay. We should give an applause for that. Thank you so much for coming, Pak.
First of all, congratulate and thanks to CISD and also Chatham House for this superb product. This is a very superb product because of several reasons. One, it is timely. Mm-hmm. It is prepared and published at a time when presidential candidates and their technocratic teams are busy looking for ideas and inspiration, and this is a very superb inspiration for everybody. Secondly, as a white paper, it is very comprehensive in a way that it is addressed the importance of public engagement. Mm-hmm. It's very important. Oftentimes, we produce policy without engaging the public. They are the subject of policies, not the object. So this is very important. Secondly, the white paper addressed a very comprehensive policy from end to end. Oftentimes, policy in Indonesia is very sectoral. This minister, this ministry only, focus on policy in their territory. This ministry only focus on policy in their territory. Money has been spent, but the outcome is not yet measured well.
Okay.
So I really buy in the ideas of health in all policies. Instead of focus on sectoral base, we have to focus more on regional, on spatial base. That's the number two. Number three, the white paper also address the importance of solid delivery. Policy, it can be perfect, but without solid delivery, cannot be enjoyed by the people. Question about whether we would like to implement this or not. Of course, yes. As a matter of fact, our camp has prepared a written manifesto. We call it Vision and Mission. It's 142 pages My apology, Bu Dia, it's thicker than your paper. Out of 8 major agenda, people well-being accounted for 25% of it. So 2 big agenda is about people, about health, about education. And I'm very happy to have a more concrete collaboration with KISD and with Chatham House. Hopefully we are lucky, so wish us luck. Let's have collaboration after June or February 2024. Again, congratulations, and please round big applause to KISD and Chatham House. Thank you.
Thank you so much, Bapak Wijayanto. So there was another cam that was raising her hand. Yes, Ibu, silakan. Can you please introduce yourself?
Okay, thank you. Honestly, I'm so nervous to have such a great opportunity to involve in here. Let me introduce myself. I am Eva. I am from Puskesmas Tegarejo, Kota Yogyakarta. Maybe I will deliver with bahasa due to my limitation in English.
Oke,
Mohon maaf.
tapi sebentar. Ibu masuk anggota tim kampanye yang mana nih?
Oh tidak,
Oh,
kalau
tidak.
kalau saya non-blok Bu.
Oh non-blok, oke sebentar, saya mau cek dulu, adakah yang lain dari tim kampanye calon presiden selain Pak Wijayanto dari Anies Mohaimin? Gak ada ya? Oke, just remember everyone, we have invited all 3, if only one comes here then it's not our fault, okay? Remember that. Oke, so Ibu jadi punya pertanyaan?
Iya, saya punya pertanyaan, ya. Saya punya pertanyaan seperti Ibu Dokter tadi yang dari Akselerasi Puskesmas Indonesia, saya mungkin ingin bercerita bahwa Puskesmas itu memang pekerjaannya banyak pertama ya Bu ya. Kemudian saya adalah seorang bidan yang menangani banyak sekali kasus ibu dan anak khususnya. Dan permasalahan yang utama itu adalah kami banyak menangani ketidaksiapan kehamilan, baik itu kehamilan remaja maupun kehamilan yang kedua, ketiga, yang sebetulnya ibu ini adalah dia ingin berhenti saja tapi tidak memiliki hak ataupun power untuk itu. Itu yang pertama. Yang kedua, ketika pasien-pasien ini tidak memiliki akses untuk BPJS seperti itu, kita sangat kesulitan Bu. Jadi datang juga karena tidak siap hamil, akhirnya tidak ANC, datang sudah memiliki tambahan yang bahaya seperti tensi tinggi gitu. Kita harus merujuk tetapi tidak ada penanggung jawab. Kita itu bingung Bu, antara saya melaksanakan sebagai petugas gitu dengan memikirkan kondisi pasien juga.
Oke,
gitu.
Ibu, pertanyaannya apa dan untuk siapa?
Ya, pertanyaannya ini di sini saya rasa karena saling terkait ya Bu ya. Jadi monggo bisa siapa saja yang bisa gitu. Kami mohon ibaratnya di garda depan itu diberi kebijakan untuk pasien-pasien seperti ini supaya kita tidak bingung, supaya kita tuh fokusnya pelayanan gitu. Saya malah inginnya begitu pasien ada tidak memikirkan biaya, tidak memikirkan latar belakang, saya
Langsung
ingin melayani seperti itu. Terima kasih.
Sorry Ibu, boleh disebutkan namanya lagi tadi?
Eva Nurul Fianti.
Dari
Puskesmas Tegarejo, Kota Jogja.
Oke, Puskesmas Tegarejo.
Ya.
Oke, terima kasih Ibu. Kami kembali ke bahasa Inggris dulu ya.
Silakan.
Okay, thank you. The question from Ibu Eva actually kickstarts our question and answer session automatically. So I would like to invite you to, again, if you have any questions that you would like to ask, you can scan the QR code in front of you or click the link that are in the table in front of you. Please do write your questions and who you would like to address them to.
Sophie,
Yes?
If I may, 10 seconds to respond to Pak Wijayanto.
Oh,
Samirin.
sure. Thank you.
Pak Wijayanto, I'm so sorry, but our white paper is 5 times aesthetics comparing to yours, Pak.
Okay.
It's a comprehensive 12 books. What you have, only 2 out of 12. So the other 10 you can find in the in our website, and I think the total number of pages, perhaps close to 600 pages in total.
There you go, lots of ideas that you can master, Pak. Okay.
And also, I think one representative from Pak Ganjar and Pak Mahfud's team was here, but I think he had to leave early. Pak Ricky Sugiarto was here.
Okay.
Yeah.
Okay. Yeah, but definitely you will send the white paper to all of the three candidates, right? Okay. Okay. Next, we are going to the questions. Thank you very much for all your questions, audience. They were all of very high quality. In the essence of time, the CISDI team has curated them into 6 questions, divided into 2 Q&A sessions, plus the question from Ibu Eva. But don't worry, because the research team will try to answer all questions through the Slido platform. Okay, let's have the questions. First, how does the Indonesian Health Assembly, LOOP, differ from Survey Mawas Diri that would be integrated with Musrenbang, and should it be different? Okay, I'm a bit confused who this question is supposed to be for. Oh, okay, Mbak Diah will answer that. And then the second one, corruption and red tape are not specifically mentioned. How are the roles of eradicating these 2 obstacles will improve Indonesia's health sector? I would like this to be answered by Professor Kent Buse and perhaps Pak Yudo. Sekalian ya, Pak Yodi. Oh my goodness. Okay, it's getting late. For the second question. And then the third one, how to follow Chatham House's recommendation on spending more financing on health while the mandatory spending are no longer exist in the current Indonesian health bill. Okay, this is quite difficult. Ibu Diah, you go first.
Okay, we built the looping framework knowing full well, and we studied the current existing frameworks and mechanisms that we have. The most notable one is Musrenbang, and also the Rakerkesnas, or the annual meeting for provincial health office and district health office leaders to come. This is one Musrenbang is more across development areas, while Rakerkesnas is directed specifically towards health annual gathering. Our observation and insight and inputs from our experts pointed us to the direction that there is a disconnect between what happens in the Musrenbang and what happens in the Rakerkesnas. The alignment of timing is not correct. So inputs from Rakerkesnas came later than what is needed for the Musrenbang, which is the overall development agenda priority setting. Also, if you remember, I mentioned about the requirement, the precondition of this Indonesia Health Assembly to work is that it is done based on impact, and it is not done as something irregular, not as business as usual, not as something that you just cross off your budget list because it's already budgeted for the coming year. The third difference is that it looks at 3 levels of governments as in a horizon, equal, not community, not hierarchical. It's not going up, but it's going to the right side, if you will. So it's in equal horizontal shape, and it connects everything in a loop, and it makes sure that actors can give their input meaningfully, inclusively, at all levels of government, despite their closeness or not closeness to policy makers. Because Professor Buse's book also mentioned that governance tend to be state heavy. Policy making tends to be government and state heavy. And that inadvertently exclude civil society because there is an absence in sustained platform. So the Indonesia health system, Indonesia health assembly mechanism ensure there is this sustained platform and it doesn't look at 3 levels of government in a hierarchical manner. But we are not creating this, another mechanism. It's reforming what we have, what Indonesia already have now, just to better align input from the health sector towards the input in Musrenbang, and then go on to RPJMN or the medium long-term plan planning for the next 5. So it's just a realignment of 3 different processes into one.
Okay, can you also give a response for Ibu Eva's question and remarks earlier?
Thank you, Ibu, for coming, and I believe that we tried to, our departure point was exactly what you said, that if you give attention to the movie that we played in the beginning, your story is exactly the kasih story. And we see you, we heard you as one like kasih, but also like many others, and that's why that triggers us to do this white paper. I hope when Pak Wija has his luck, or Pak Ricky has his luck, Pak Arsyad has his luck, then we hope this, what we recommend in the white paper can be uptaken into a real policy that can overturn this condition.
Okay, thank you. So for the second question, I think it is best to hear answers from Professor Buse as well as Dr. Malik. So we would like to compare notes again regarding this one. So the corruption and red tape are not specifically mentioned. How are the roles of eradicating these 2 obstacles will improve Indonesia's health sector?
Okay. Can you hear me?
Yeah.
I don't think I should speak specifically to corruption and red tape in Indonesia, but I just want to build on some comments that have come up in the room already, and sort of implicit in the last question as well, and that I think that there are a number of things in health systems that we'd like to see changed, and I really agree with the representative of the political party that we need to stop treating people as objects, but as partners in policy making. And you know, I've been around long enough that I was party to the disability rights movement, saying nothing about us without us, and the same went for the HIV movement, nothing about us without us, and the women's rights movement in the last 5 years, pointing out the inequities in a healthcare system that's delivered mainly by women, but run mainly by men, and looking for policies to be put in place so that there's equality of opportunities. Equalities in relation to all the intersectional challenges that Dr. Goen referred to earlier. So I think that there's something to be said for involving people in policy making and in the oversight of that, delivery of that policy, as we've heard as well. And so I think that one approach universally to getting rid of corruption in the health sector and other undesirable factors is institutionalizing social participation, institutionalizing meaningful engagement, and there to be systems of accountability around those strengthened so that the outputs from those meaningful engagements, that social participation at every level, including in the parliaments that, the health parliament that the white paper refers to, are actually acted upon. So that's my roundabout way of saying more institutionalized social participation will hopefully deal with some of these issues, as will having more representative leadership in the sectors, that leadership that reflects the workforce and leadership that reflects the people that are being served.
Okay, thank you so much. So now let's compare notes again with Maldives. Of course, we are not asking you to talk about Indonesian corruption and red tapes, but how do you approach this in your country?
Thank you. One thing I would like to point out at first is the red flag, green flag, the quadrants that is in the white paper. The value-based governance is similar to what Professor Bruce just mentioned. When it's value-based and these values come from people across the board, that's when the change can happen towards the green flag governance. I'll just take maybe a couple of examples of some changes that has been done in the health sector systematically within the past 5-6 years, is involving a public sector or a community person sitting on these boards where the decisions are made. And for example, the regional hospital board will have one person from representing the public health sector, one person representing the people of that particular island or atoll community, and then also the technocrats and the bureaucrats and the policy people. So when these representation is across the board, it is there, it is harder for corruption to seep in. But then again, bureaucracy, red tape might come because of the layers. So it's a balance that you have to bring when it is within the system, when it is institutionalized, but at the same time, with least number of layers is how we can go towards achieving these two things at the same time. I like the value-based governance quadrant going towards the green flag, and that in the white paper is a key element for driving towards what the question is referring to.
Okay.
Thank you.
Thank you so much. Okay, so Pak Yudi, I actually have a more fitting question for you. That was the third question. If I may mention once again, how to follow Chatham House's recommendation on spending more financing on health while mandatory spending no longer exists in Indonesia's health bill? I think you really need to answer that.
Well, I would like to answer the second question first, because
Sure.
that's a really, this is
okay.
corruption issues in healthcare, because I think it's a big issue, and it was mentioned as a question, and there has been reports that corruption and fraud has contributed to the deficits of our JKN, so that there are reports of that. So of course, if you can do something about that, it will improve our JKN, improve our efforts to increase universal health coverage. Because there have been reports of frauds in terms of billing for services not rendered, unnecessary medical tests and treatments, we have kickbacks, we have third-party fraud, bribery, among others. So that's documented, so we have that. So that's there. And more recently, also more timely, during the COVID-19 pandemic, we saw that the risk of fraud and corruption increased to uncertainty and disruptions rising from the emergency, which allowed some actors to take advantage of situation for private gain. And as we speak, I think everyone in the room are aware that there are some investigation ongoing regarding some of the potentials, corruptions and fraud in terms of the COVID-19 pandemic response. So the answer to that second question, I think it would have a lot of leverage, because it is one of the factors which have contributed to the deficit of our universal health care, and it also plays a role in our pandemic response as well. So I think that needs to be noted. I actually don't have much answer to the third questions. I'm not really the health financing experts. I would agree what Ibu Diah was saying. I mean, we need much more innovative financing schemes because that mandatory is no longer there. So because it's no longer there, then we need to be innovative. And that is something that we have to do together to be able to do that. I think we have a financing expert here, Professor Hasbullah. I think I saw he's sitting over there. Perhaps he can contribute, because he's the expert of health finance expert. If you give him the time, perhaps he can contribute in terms of that third question.
Okay. CISDI team, let me know if you have more time for that. But if I would like to address the third question again, probably from Prof. Hera or Ibu Diah. We no longer have the mandatory spending in our health bill. So how can we follow the Chatham House's recommendation for on spending more financing on health, while we no longer have that. Do you probably have any response to that, Prof. Hera, Ibu Dia?
So Prof. Hera's directive is that I answer the question.
Okay, okay.
So yes, it's a bit difficult. There is, again, Prof. Hasbullah perhaps can shed a light on that. But from what CISDI has discovered, we see deletion of mandatory spending from this current situation puts health priority in a more volatile stage.
Okay.
Especially to ensure commitments in subnational level. Because what no mandatory spending means is that health budget can go up and down.
Mm-hmm.
We put in a white paper that currently it's 5.6%, but next year it might be different. The next it might be different. Yes, it can go up, but it can also go down. Health, if we refer to Thailand, health is in their constitution.
Mm-hmm.
Here in Indonesia, education is in the constitution, the budget 20%. But health is put on deletion in mandatory spending, making it very difficult to plan for multi-years.
Yeah.
Planning for multi-years does not always mean planning and budgeting go at the same time. So planning for multi-years can also mean setting a priority for the next 3 to 5 years for health, and then you plan on the budget for the next 3 to 5 years. But it's going to be difficult to plan like that if there is no certainty in the budget even for the coming year.
Okay.
And then second, if we are talking about governing, there is still, maternal mortality is still high, stunting is still high, we have the double burden of nutrition, so underweight and overweight. There are so many NCDs, there are so many health demand that needs to be taken care of by the government, by policymakers, and priorities usually come from the top, from central government. So there is a strategic priority for health. Political will. So that strategic priority then is communicated to the public, and the public also, the subnational level is also the public.
Okay.
So if there is no commitment on the budget, it will be very difficult to have for that priority to be reflected at subnational level as it is called for at the central government.
Okay, so we have right about 2 minutes to listen to what Professor Hasbullah needs to say, because really it's mind-boggling to me as well, because we no longer have the mandatory spending. How do we increase the spending on health financing then? Yeah.
Yeah, thank you very much. Sorry, I'm not preparing for this, but this is what I heard. I didn't follow the meeting in the parliament or the Congress, but what I got information is that the Ministry of Finance, since long time I know, that they don't like the idea of mandatory spending, which make them not flexible in allocating budget. So therefore they said, let's delete that, let's have a consensus, agree on what we are going to propose in the health sector for the midterm. They call it Rencana Induk Bidang Kesehatan, which is midterm planning for health sectors. Once we agree what we are going to do and what needs to be done, then we negotiate the budget.
Yeah.
So that's what they want to do it. Currently, this is Rebecca in the law. If you read chapter 13, it's in the law. In addition to that, there is also mandate that the government should develop the health health financing information system, which will be based for the health planning and budgeting. So they want to be much more collaborative work. It is, again, as Rob mentioned, will be political decision among the Minister of Finance, Minister of Health, and I suppose Minister of Planning.
Okay.
So that's what happening. It can be high risk, as Mbak Dia mentioning, but it can be also good opportunity depending how we deal, we negotiate, provide evidence on what the needs of health funding. Certainly, if we read a World Bank document, we need to spend more, spend better, and spend right for health.
Okay, thank you, Pak. Round of applause for Professor Hasbullah. But that highlights the importance of having a very, very strong and good negotiator in the health sector in order to be able to negotiate the kind of budget that currently is not set up, right? Okay, so you have more work to do, my dear.
Sophie?
Yes? Yeah. Okay, we are going to the second round of questions. I would like to read all three of them first. First, could you provide insights on how the paper specifically addresses indigenous health equity in Indonesia, considering them as one of the vulnerable groups? This is for Mr. Abdul Malik. And then the second question, if the intervention would be implemented for the gender equality in the dominance of patriarchy, how long the processes could be done, and what are the influencing factors? This is for Dr. Karen Ground. I hope that we have already established our connection with Dr. Karen Ground. And then the third one, we have already established policy on human resource credentials in 2019. How can we guarantee human resources competency, particularly for nurses in Puskesmas? This is for Professor Hera. So shall we try to answer the first question? Mr. Malik?
Thank you. First, I would like to go into how it's done back in Maldives. Again, like our very vastly spread island communities, which are sustained on their own and run as their own communities. How they do this back home is they have their own priorities within the island. They have their own issues that they identify, and they have their own ways how to address it. And to institutionalize this in a governance form, the local council, the local government is present. But having said that, when it comes to especially things like health, our previous health setup is such that there are local traditional healers within the island who are still, even till date, accepted by the community as really good resource people, even if we have modern medicine and hospitals within the country, even in the island level. So we have to listen to them and take on their advice. And then the second part is linking up to the white paper itself, the conversations that were held with the local level, with the, if I may use the word, indigenous communities, which we don't use back in Maldives because we are all island communities across the board. We do not differentiate indigenous or non-indigenous as such. So here, the conversations that were held with them and getting their feedback, getting their voice heard is how the paper has become so comprehensive in this note. Another factor that I would like to add is that when it's a large city urban area and comparing it with a small archipelago, like further away from the mainland, that health systems, health services, health interventions will not be the same. There is no such thing as one size fits all when it comes to serving different levels of communities. So that is another point that is very apparent. And when it comes to small islands and when it comes to places like Indonesia and even Maldives, where climate change and disasters are prone, this factor actually impedes even livelihoods. And when this happens, health becomes secondary, because first and foremost, if someone loses their livelihood completely, their biggest priority would be how do we get that back. So there has to be a system where a resilience community has to be built even after a disaster or climate incident happens. So that has to be factored in. I think the levels of health assembly that was in it covers well how the voices of the indigenous people and how equity can be brought in. So in our case, it is one island decides how their health services are run, but then at the same time, equitable, all the basic necessary primary health care services has to be there. I mean, that's the minimum requirement at a government level. I think if the team or Budia would like to add, I would leave it there.
Okay, we'll see about that, Mr. Malik. Okay, next question is for Dr. Karen Brown. Can you hear us?
She can.
I can hear you. Can you hear me?
But can we hear her?
Can you hear me? I can hear you. Can you hear me?
Yay. Finally, yay! Everybody in the room is clapping. Okay, Dr. Brown, if the intervention would be implemented for the gender equality in the dominance of patriarchy, how long do you think the processes could be done, and what are the influencing factors? This is a huge question.
Well, frankly, the struggle for women's rights and gender equality is a very long-term struggle. And if current trends continue and it's business as usual, it could be more than 100 years before we achieve parity. And that doesn't even address women's empowerment. That's just parity. So I think it's really important. A lot of what the speakers have been mentioning are really critical for us as well. A people-centered system, or putting the lens of women's empowerment and gender equality at the center, will get us there faster than if we think of this as separate interventions and separate add-ons. So I think there's a number of things that just have to happen. This is bound up with the financing conversation, because we need to actually pay workers more. We need to bring more community workers into the formal system. There's many things that have to be done that require resources. We need to invest in data systems. We don't have the right data yet. We don't have enough of the data. We don't have a good enough analysis of the data for targeting. That requires investment and resources. And I think probably the most important thing, as others have said, is political will. And gender equality or women's rights are the political football, and particularly around sexual and reproductive health, maternal health. Several of the panelists have mentioned issues like nutrition, maternal mortality, other things, but the ways in which the health issues are dealt with are really for the roles of women as mothers, as opposed to women as powerful actors and change agents as part of a system who have economic needs as well as needs for their families. And that's going to take a while to change the orientation of the system. And it can't only be the health system. It has to be societal change, norms change that happen outside the system as well as the system.
Okay, that's huge. Thank you so much.
It's really
Dr.
huge, but that's where women's organizations,
I
civil
know.
society, other NGOs are really important. That advocacy agenda that others have referred to, and giving those organizations and institutions a place at the table so their voices are heard is critical.
If it needs 100 years or even more, so be it. Okay, thank you, Dr. Ground. And then the third question for Professor Hera. We have already established policy on human resource credentials in 2019. How can we guarantee human resources competency, particularly for nurses in Puskesmas?
Thank you very much for the question. I think I would like to start first that Indonesian Academy of Sciences recognize there are gaps in translating evidence to health policy. And one of or two or three possibilities because of the validity of data, information to prove what actually happened in Indonesia for decades. Lack of that good data management related to the quality and inconsistency data taken from the region or national level. So here we have problem, and we know that Puskesmas is the ujung tombak of the system, I think the forefront of the health system. So how can we guarantee the human resources competency for nurses? And we know that there are some competency tests actually regarding this to have or to be able to get a nurse with a good competence. There are 3, maybe 4, 5, or more than 10 points that we should actually see. The patient-centered care, the teamwork and collaboration, evidence-based practice, say for example, quality improvement, safety, and the last one, informatics. What about actually preparing them to the next future of the digital health technology? So we have problem. We don't have money, we don't have funding. I heard that I hope that the next administration will put it into their priority. And that's the problem. So education is important for the competency in a continuation. So it has to be continued, it has to be sustained to be able to get a good and competent nurse in Puskesmas. But we have to solve, again, that we cannot just put it into our plan without even give a solution to it.
Okay.
And that solution that we actually search here.
Okay.
Thank you.
Okay, thank you, Professor Hera. Thank you. So, yes, please give a warm round of applause for all our panelists here. Thank you so much. Unfortunately, we are running out of time. We're actually late. But let me have some key takeaways from our discussions, as well as the Q&A, in developing the health sector, especially in Indonesia. The first one, just like what Professor Yodi said, inequity, inequity, inequity. That is the first one that needs to be addressed. That is the first one that needs to be acknowledged, and we need to find solutions for that. And then second one, what is more important, especially for Indonesia, with the kind of structural system, with the kind of political structure, as well as the kind of archipelago that we have, decentralization might be a very interesting and important part. And then mirroring what Professor Buse was saying, political will definitely needs to be there. And then we need to look at the social structure as well as system. And what Professor Hera was saying is it regarding the evidence-informed policy making, which is based on data, data, and data. And then last but not least, this is one of the most complex but important factor that we should put into when making when developing health sectors, especially in Indonesia, is that intersectionality, including climate change, local content, and community perspectives, as well as gender, feminism, and socio-economic structure that we currently have in Indonesia. So thank you all speakers for the great panel session we just had today. Thank you for all of you who have been participating in this event. I would like to invite all of you to give one more applause for our panelists, Dr. Malik, Dr. Yodi, Professor Buse, Professor Herawati, and Ibu Diah Saminarsi, as well as Dr. Karen Ground, who is participating online from Washington, D.C. So, ladies and gentlemen, once again, I would like to remind you that you can access all 13 books for the white paper through the QR code, as well as the link that you have in front of you on your table. After this session, you can enjoy lunch available on the foyer, both in this floor as well as on the first floor. And then after lunch, there will be competence forum in 4 separate rooms downstairs. And if you are not applying to one of the competence forum session, you can enjoy booths and exhibitions on the foyer. We will have all the schedule of the competence forum right here. You can definitely read that and make sure that you have already registered if you are interested in joining the competence forums. Okay, so now my time is up. I'm Sophie Sharif. Thank you so much for having been with us since around about 9 a.m. this morning. And once again, a huge applause for CISDI team and their white paper. Thank you so much. Have a lovely lunch. I'll see you again next time. Thank you. Goodbye. Terima kasih, Pak Yodi. Thank you, Pak Malik.
Tes. Kepada rekan-rekan wartawan dan knowledge partner, silakan tetap di ruangan karena press conference akan dimulai sebentar lagi. Silakan bisa mengisi kursi yang ada di depan.
Recording stopped.
Sekali lagi kepada rekan-rekan wartawan dan knowledge partners, Silakan tetap di ruangan karena press conference akan dimulai sebentar lagi. Silakan mengisi kursi di barisan depan. Iya, mana? Ini ya, teman-teman wartawan ya.
Balik lagi apa gimana?
Udah aman, apa? Ingatin aja.
Kalau butuh apa-apa WA aja mas.
Yuk. Ini Mbak Sofi, headset yang kedua. Udah. Di situ. Kita nggak jadi pakai ini, nggak jadi pakai set di stage karena kan lebih sedikit ya orangnya, jadi lebih private aja. Nggak pakai mic.
desire believe when I say I want it that way.
When we are two worlds apart, you can't reach to your heart. When you say that I want it that way,
Tell me why ain't nothing but a heartache. Tell me why ain't nothing but a mistake. Tell me why I never wanna hear you say I want it that way. Am I your fire, your one desire? 'Cause I know it's too late, but I want it that way. Tell me why ain't nothing but a heartache. Tell me why ain't nothing but a mistake. Tell me why I never wanna hear you say I want it that way. Now I can see that we're falling apart from the way that it used to be. Yeah, no matter the distance, I want you to know that deep down inside of me,
you are my fire, the one desire.
you are.
You are, you are.
Don't wanna hear you say nothing but a heartache. Ain't nothing but a mistake. I never wanna hear you say, oh yeah, I want it that way. Tell me why ain't nothing but a heartache. Ain't nothing but a mistake. Tell me why I never wanna hear you say I want it that way. 'Cause I want it that way.
One, two, three. I know your eyes in the morning sun. I feel you touch me in the pouring rain. And the moment that you wander far from me, I wanna feel you in my arms again. And you come to me on a summer breeze, keep me warm in your love when you softly leave. And it's me you need to show. How deep is your love? How deep is your love? I really need to love. 'Cause we're living in a world of fools, breaking us down when they all should let us be. We belong to you and me. I believe in you. You know the door to my very soul. You're the light in my deepest, darkest hour. You're my savior when I fall. And there ain't nothing that I care for you, and you know down inside that I really do. And it's me you need to show. How deep is your love? How deep is your love? I really need to love. softly leave. And it's me you need to show. How deep is your love? How deep is your love? I really need to love. 'Cause we're living in a world of fools, breaking us down when they all should let us be. We belong to you and me. Yeah, yeah. How deep is your love? How deep is your love? Oh, how deep is your love? How deep is your love? Ooh, how deep is your love? How deep is your love? One, two, three.
The club isn't the best place to find a lover, so the bar is where I go. Me and my friends at the table doing shots, drinking fast, and then we talk slow. You come over and start up a conversation with just me, and trust me, I'll give it a chance. Now take my hand, stop, then the man on the jukebox, and then we start to dance.
I'm singing like, girl, you know I want your love. Your love was handmade for somebody like me. Come on now, follow my lead. I may be crazy, don't mind me.
Say, boy, let's not talk too much. Grab on my waist and put that body on me.
Come on now, follow my lead.
Come on now, follow my lead.
I'm in love with the shape of you. We push and pull like a magnet do. Although my heart is falling too. I'm in love with your body. Last night you were in my room, and now my bed sheets smell like you. Every day discovering something brand new. I'm in love with your body. Ooh, I'm in love with your body.
One weekend, we let the story begin. We're going out on our first date. You and me at 50, so go all you can eat. Fill up your bag and I fill up my plate. We talk for hours and hours about the sweet and the sour, and how your family's doing okay. Leaving, getting a taxi, kissing the backseat, tell the driver make the radio play.
I'm singing like, girl, you know I want your love. Your love was handmade for somebody like me. Come on now, follow my lead. I may be crazy, don't mind me.
Say, boy, let's not talk too much. Grab on my waist and put that body on me.
Come on now, follow my lead.
Come on now, follow my lead.
I'm in love with the shape of you. We push and pull like a magnet do. Although my heart is falling too. I'm in love with your body. Last night you were in my room, and now my bed sheets smell like you. Every day discovering something brand new. I'm in love with your body. Ooh, I'm in love with your body. Ooh,
I'm in love with your body.
Come on, be my baby, come on. Come on, be my baby, yeah. Come on, be my baby, come on.
Come on, be my baby.
I'm in love with the shape of you. We push and pull like a magnet do. Although my heart is falling too. I'm in love with your body. Last night you were in my room, and now my bed sheets smell like you. Every day discovering something brand new. I'm in love with your body. Ooh, I'm in love with your body. Ooh,
I'm in love with your body.
come on, be my baby, come on. Come on, be my baby. Yeah. Come on, be my baby, come on. I'm in love with the shape of you. I could stay awake just to hear you breathing. Watch you smile while you are sleeping, while you're far away and dreaming. And I could spend my life in this sweet surrender. I could stay lost in this moment forever. Every moment spent with you is a moment I treasure. Oh yeah, I don't wanna close my eyes, I don't wanna fall asleep, 'cause I miss you, babe, and I don't wanna miss a thing. 'Cause even when I dream of you, the sweetest dream will never do, I still miss you, babe, and I don't wanna miss a thing. Lying close to you, feeling your heart beating, and I'm wondering what you're dreaming, wondering if it's me you're seeing. And then I kiss your eyes and thank God we're together. I just wanna stay with you in this moment forever, forever and ever. I don't wanna close my eyes, I don't wanna fall asleep, 'cause I miss you, babe, and I don't wanna miss a thing. 'Cause even when I dream of you, the sweetest dream will never do, I still miss you, babe, and I don't wanna miss a thing. I don't wanna miss one smile, I don't wanna miss one kiss. Oh, I just wanna be with you, right here with you, just like this. And I just wanna hold you close, feel your heart so close to mine, and just stay here in this moment for all of the rest of time. Oh yeah, yeah, yeah. I don't wanna close my eyes, I don't wanna fall asleep, 'cause I miss you, babe, and I don't wanna miss a thing. 'Cause even when I dream of you, the sweetest dream will never do, I still miss you, babe, and I don't wanna miss a thing. Oh, the sweetest dream will never do, I still miss you, babe, and I don't wanna miss a thing. Baby, now that I found you, I won't let you go. I build my world around you, I need you so. Yeah, baby, even though you don't need me now. Baby, baby, when we first met, I knew in this heart of mine, you were someone I couldn't forget. Sit right and bide my time. Spend my life looking for that somebody.
Gak iso.